So welcome back to the second day of the 9th annual Montreal Oscillometry seminar. We're coming to you live from McGill campus, as I told you yesterday. And for those of you who've missed any part of it or want to review it again, everything will be archived on the website of Respiratory Effectiveness Group and in the Technologies Working Group page. And thank you very much to our corporate sponsors. It's great collaborating with industry because we share goals. And then finally, that made the supper last night possible. And finally, a big thank you to everybody who was behind the scenes helping me organize it. And welcome back to the seminar. Over to you.
Well, thank you very much, Ron. I very much echo Chung Wei's comments that this is one of the best conferences of the year, and I very much enjoy it every time. Okay. Why don't you introduce yourself and take it away? Thank you very much.
Sure. Thank you so much. Wishing you all a very good morning, good evening from whichever part of the world you're listening to me. I am Disha Ghorpade, and I bring you greetings from my country, India, and from my organization, the Pulmocare Research and Education Foundation. Today, I'm going to talk about the oscillometry changes over a 3-month period with LABA/LAMA and triple therapy in patients with post-TB COPD, a multi-centric nationwide study. I'm presenting this work on behalf of all the other investigators across the country. Tuberculosis is a big problem in developing countries. And after a patient is cured from TB, the story does not end there. It then develops into post-TB sequelae. Majority of the people, 50% of the people develop this sequelae. There are 155 million TB survivors globally, of which 40 million TB survivors are living in India. Now that's equivalent to the population of Canada. Of all these TB survivors, 50% of them visit a respiratory clinic with continuous respiratory symptoms. And we conducted a study across 27 centers in India amongst 618 post-TB patients who had an infection of post-TB, and we did a spirometry in them. And we found that 54% had developed COPD, that is spirometry defined FEV1 by FVC post-bronchodilator ratio, and 26% developed PRISM, that is preserved ratio impaired spirometry, now known as early COPD. What I would like to point out over here is only 9% developed asthma and 11% had a normal spirometry. So majority of the post-TB patients developed COPD or pre-COPD, that is 3/4 of the total population. Now, this is what we saw at our center in India, but a very recent study published in the Lancet just this year showed that there is a significant decline in lung function through various studies across the globe. So yes, there is a huge and a growing burden of post-TB COPD. And despite this huge burden, to the best of our knowledge, there is very little literature or no literature on what is the right pharmacotherapy for post-TB COPD. And therefore, my research question as to what is the therapeutic efficacy of post-TB COPD treated patients by LABA/LAMA and triple therapy at baseline and post-3-month treatment as evaluated by lung oscillometry. To do this particular study, this was done through the International Network for Lung Oscillometry Research, also known as the ARISE network that we run at our center. This particular data was collected from across 10 centers across 7 states, and we had a total of 183 post-TB declared cured COPD patients. At baseline, we had a total of 141 patients and 3-month follow-up of 107 patients. But what I'm going to present is a data for only baseline versus the 3-month follow-up visit. The inclusion-exclusion criteria, as you all can see, male and female participants more than 18 years of age, diagnosed cases of post-TB COPD who are not currently having the infection, and a spirometry ratio of post-bronchodilator less than 70%. All those patients who were currently on COX treatment, or there was a relapse case of TB as defined by the physician, or cases of asthma, were all excluded from the study. They were administered a questionnaire which had demographics, symptoms, risk factors, comorbid conditions, spirometry, and lung oscillometry. The demographic distribution, we had 72.7% males in the study. The mean age of the study population was 63, and the TB duration, that is the date of diagnosis of TB until the visit to the clinic or recruitment in the study, the mean number of years was 24 years. The symptoms that were reported, the majority of the participants reported us the symptom of shortness of breath, followed by persistent cough, wheeze, and chest tightness. The various comorbid conditions were also recorded, with 30.6% reporting hypertension. And this was the list of all the treatments that were prescribed, and of which LABA-LAMA ICS, that is triple therapy, was seen in majority of the participants, as well as LABA and LAMA. So what I'm going to compare, the data that I'm going to show is a comparison between triple therapy and LABA-LAMA, and not consider LABA ICS because of the low sample size. So here is the spirometry data. So if you see over here, there was a significant mean change from baseline to visit 3 in both the treatment regimens, in LABA-LAMA versus the triple therapy. What I would like to point out over here is that FEF 25 to 75, which is an indicator of small airways, LABA-LAMA showed no significant improvement on spirometry, though the other parameters like FEV1 and FVC did show significant improvements. But here is the highlight of my talk: resistances, R5, R20, R5 minus, R20, and AX from baseline to visit 3. Both LABA-LAMA versus triple therapy all showed a very significant improvement from the mean values at baseline versus visit 3, which was post 3-month of treatment. AX, here I would also like to point out that AX, that is area of reactance, which also indicates small airways obstruction, also showed a very good improvement. So if you see at baseline, it was 20.6, and at visit 3 is 7.29, more than 60% change. Similarly, the triple therapy, 32.7 to 20.2, more than 30% improvement, 35% improvement. So yes, your lung oscillometer also can pick up small airways in post-TB. X5 also showed a significant improvement. So to conclude, AX, or area of reactance, demonstrated significant decline with both treatment regimens, indicating improvement in small airways function. The decline in AX supports the hypothesis that the pathology of post-TB COPD predominantly involves the distal or the small airways. Oscillometry effectively captured treatment response with AX, not only AX, with the other parameters as well, showing a good decrement of more than 60%, highlighting its sensitivity in monitoring symptoms in small airways, changes in the smaller airways. While spirometry failed to show any improvement with LABA-LAMA, lung oscillometry detected a significant positive response, reinforcing its value in assessing distal airways involvement. Thank you very much.
Very much, Disha. Are there questions in the room? Larry's first.
Thank you. That was really very interesting. My question is, the majority if I look at it from the side of view of bronchiectasis, the number one cause of bronchiectasis in India, my understanding, is tuberculosis. And I'll call bronchiectasis, let's say, loss of small airway wall integrity. So my question, I'm not denying your results. I think they're very impressive. But is this COPD versus a small airway loss of wall integrity? When I think of COPD as sort of emphysematous type of changes, but wondering about the actual pathology. I'm not denying the response. I'm just wondering the pathology.
Yes, absolutely. I may not be able to answer your question appropriately, but yes, absolutely. The point that you've raised is can definitely be taken into consideration.
Disha, good to see you again. And likewise, I echo Larry's comment. Great talk. I love the work you guys do. You're binning people into the category of asthma or COPD is it based on a tobacco history or a biomass exposure history or not? And so those without biomass or tobacco history, you would call asthma with their obstructive pattern? Or am I reading too much into it? How did you split those two groups? Because they both may demonstrate obstructive spirometry.
Yes, Ron, you're absolutely right. This could be one of the biases in our studies because we've included both biomass exposed as well as smokers, and in order to kind of remove those confounders, we should have not included smokers in our study. So yes, we've included both of them, and that could be one of our limitations.
Well, if you have, what's your proportion of biomass COPD versus tobacco COPD? If you have relatively equal groups, all you need to do is segregate them, because obviously the biomass will be much younger because they're going into early adulthood with established COPD, unlike the smokers, who I presume in your area of the world end up being older as they come online with their disease.
Right. So we had around 30% of biomass exposed participants.
So you could divide the groups up and take a look at it. It'd be interesting to see the difference between them. Also, the biometrics and the age will be good.
The smokers probably had both exposures.
That's so, Alicia?
Yeah.
So those who smoke tobacco would have already started off with COPD in adolescence.
Yeah, I think David, basically.
Disha, my question is, do you have a measure of more central airway resistance like R19 or R20? And it relates to Larry's question before. I think a bronchiectasis is occurring definitely in medium-sized airways as well as small airways. So I'd be curious to see if you were able to pick that up on the oscillometry.
Unfortunately, we haven't looked at that. So I don't have the data right now to present to you.
Okay, thank you.
I thought I saw that there was R20 represented in the groups, and they were actually different, but the differences were minor compared to the R5AX and R5 minus 19. Yeah. I was going to. Jason, if you could ask.
I'm going to be a naysayer. Very interesting results, and you have a big result, so that's very important. I'm going to be a naysayer and say I'm not so sure about this peripheral versus airway discrimination. I have more work to do to figure this out. I talked about it yesterday, but I would caution you to be more circumspect in saying that this is small versus large airway discrimination. I'm not convinced FOT can do that. I'll just leave it there.
Well, I'll add to Jason's words there. So you published actually a paper that showed R5 minus 19 or R5 minus 20 was sensitive to heterogeneity. Irrespective of how the heterogeneity was laid out, it could be upper versus peripheral, but it also could be just peripheral heterogeneity, right? Or it could be heterogeneity in the top.
Parallel of some kind.
Parallel of some kind.
Yeah.
So it was, whereas R20 was more the homogeneous resistance of the airway, which included small airways sometimes if they were significant with the large, with simple simulations. So I completely agree. In diseases like asthma, where you have pictures where the obstruction tends to be in the periphery and R5 minus 19 tends to be the one that's showing it, we're convinced small airways, but then we're kind of biased to that image that we saw from asthma. We transfer it to bronchiectasis, which may not be right at all.
Yeah, I mean, the thing is, for it truly to be peripheral versus central airway, you have to have a significant intermediate compliance, which means the compliance of the airway tree itself has to matter. And that's a little equivocal.
Right.
Online.
We should go online.
Disha, if you stop sharing your screen, we can bring a few people online into the conversation. Oh, Pedro's there just calling out.
Pedro, do you want to share your screen
Or
put on your video? Turn on your sound?
if he doesn't, I'll read out what he says. Maybe he doesn't have a microphone.
Yeah. I can't.
Okay,
Oh,
so
there he is.
Pedro says, Disha, congratulations. Oh, there he is. Good morning.
Good morning, everyone. Are you listen me again? Okay.
Yes.
We hear
Yeah,
you.
we can hear you.
Okay. Good morning, everyone. Disha, congratulations for your presentation. It was really nice. Post-tuberculosis is also a great problem here in Brazil. And we are conducting research in this sense using Foster oscillation too. Do you have used computer tomography in your
No, we've
studies?
not used a CT.
Mhm.
There may be some centers who may have, but we've not collected that data. We've not documented at our end.
Okay. These results are really difficult to understand because several of these patients have mixed changes, several difficult problems to understand. And we think we have a great potential to collaborate.
Absolutely. Would love to collaborate.
I sent my email in the chat, and if
Yes.
you want, we can collaborate because it is a great challenge for us.
Sure, I've taken a note of that and would definitely connect.
Okay, thank you.
Tremendous. You had a question?
Yes, actually, I have a comment to Jason, about the small areas with
Yeah,
the
can you
large.
speak up?
So my suggestion, is to look for the patients that supposedly very well controlled with the corticosteroid, and then those, that still have the symptoms that probably likely that have the small, still have the small area obstruction, despite, the control of the inflammation in the large areas.
I'll think about that. I'm not sure that's gonna be definitive.
Steroids
but
can hit the
I'll think
larger
about it.
areas too.
Yeah, yeah. The thing is, unless you have significant airway compliance, so you have that intermediate compartment, for the two compartment model, that intermediate compliance has to be the airways somehow. If it's not significant, you cannot make a distinction to serial.
Yeah, that's
Then
true.
you have one. So that's the problem. But anyway, jury's out on this, but
The jury is out. More work to be done. Are there any further questions? If not, thank you very much. Disha? Okay, I have the pleasure of introducing Sandeep Salvi. Are you online? Can you share your screen? Perfect.
Yes. Can you hear me and can you see me?
Yeah. And we can see you as well. We can hear you.
Okay, thank you.
Thank you very much. Introduce
So wish you all a very good morning and good afternoon, good evening, whichever part of the world you are listening from. I am Sandeep Salvi, the Director of Pulmocare Research and Education Foundation based in the city of Pune in India. At the outset, I would like to express my heartiest congratulations and appreciation to Ron for organizing such a brilliant oscillometry summer symposium. There is so much that that we all are learning from this very important meeting. What I'm going to do today is challenge the role of using Z-scores in interpreting oscillometry reports. So this is going to be a very provocative talk, a very provocative presentation, because based on what I saw yesterday at the Delphi results, I would be challenging some of the results of the Delphi results. So if you, these are my beliefs, and I genuinely believe in this. Oscillometry is a more sensitive tool to pick up airflow obstruction than spirometry. I have been led to believe this, and I have experienced this in my clinical practice. I also believe that oscillometry is emerging as a valuable diagnostic tool in clinical practice and is predicted to become the future of lung function testing. I have been using these statements in my presentations and my talks across the country, and especially for the last couple of years, we have been working very hard to promote oscillometry in India. Now, with these beliefs, I'd like to show you a few presentations which actually shattered my beliefs. The first one was quite a big study from China, from 4 provinces that looked at 768 patients with spirometry confirmed COPD. And in this population, they performed oscillometry and used the upper limit of normal or the lower limit of normal with a Z-score of more than 1.645 or less than 1.645 standard deviation. That is the 5th percentile or the 95th percentile. And they did a comparison between the clinical characteristics of spirometry defined COPD versus oscillometry defined COPD. And what surprised me was compared to spirometry defined COPD, oscillometry picked up only about 60% of the patients of COPD. So this came as a bit of a surprise because I genuinely believe that spirometry is more sensitive, that oscillometry is more sensitive than spirometry. When you look at the severity of the gold staging of COPD, so gold stage 1, 2, 3, 4, and you can see the various oscillometry indices and what proportion of patients were picked up for these gold stage COPDs with the different oscillometry devices. So in gold stage 1 and 2, you can see that the oscillometry indices picked up only between 30 to 60 to 70% of the cases. Gold stage 3 was around 80 to 98%, and gold stage 4, all of them. So this led me to start pondering whether oscillometry is sensitive, more sensitive than spirometry in picking up COPD. The second study is from Raipur in India, which was a retrospective data of known and diagnosed cases of 187 asthma patients and 280 COPD patients. Oscillometry was performed using the Resmon Pro full device, and the interpretation of oscillometry was based on a Z-score, either more or less than 1.645, depending on what parameter you're utilizing. And this also showed the same result. So I'm showing you both COPD and asthma patients for various oscillometry parameters, and the different color bars that you see here, from the left to right, it starts with the mild airflow obstruction to moderate, moderately severe, and severe airflow obstruction. And you can see that oscillometry indices such as R5, R19, you pick up any of those indices. In the early stage, they hardly picked up around 50 to 60% of cases of COPD as well as for asthma. So the observation that was made in China was also made in India, again indicating that oscillometry is perhaps not as sensitive as spirometry in diagnosing asthma and COPD. And finally, this paper that was just published about 10 days ago from Gothenburg in Sweden, called as the SCAPIS study, more than 10,000 participants between the ages of 50 to 64. They underwent spirometry as well as impulse oscillometry, and abnormal lung function was defined as the upper limits of normal and the lower limits of normal using a Z-score of more than or equal to or less than 1.645. That is the 5th percentile or the 95th percentile. And they also showed exactly the same. So you can see different indications over here. You have the normal population, and obviously all of them are below 5%, and that's what is expected. But if you look at the obstructive disease patients, oscillometry hardly picked up between 15 to 30% of the patients, uh, uh, which were picked up on spirometry. Same with PRISM, that is preserved ratio impaired spirometry or restrictive spirometry pattern, or a combination of PRISM and restrictive spirometry pattern. So very disappointing that oscillometry picks up far less number of patients with various lung ailments, including asthma and COPD. Oscillometry picks up than what spirometry does. So this really upset me, and it started shaking my belief that oscillometry is not as sensitive or more sensitive than spirometry. So there are two options. One is that oscillometry is far less sensitive than spirometry in picking up asthma and COPD. Maybe that's the reality. But there could also be another possibility that are we using the wrong diagnostic criteria to differentiate between normal and abnormal? Because the three studies that I presented are now being read by people all over the world. And the feeling that you tend to get after reading these papers is, oh, oscillometry is not as good as what spirometry is. And that was something that was really worrying me. So let me take you through what my thought process was. If you have developed a diagnostic test or a tool, how do we differentiate between normal and abnormal? And one of the ways of doing that is to take a healthy population from the local area, and you draw the distribution pattern of the results, and then make an assumption that 5% of the data will be abnormal, 2.5% on the left side, 2.5% on the right side. And therefore, the possibility of you making a mistake if you use these cutoff values is only about 5%. It's a statistically developed cutoff tool. This is what is used in most other tests. So if you take all the blood tests or if you take any other test, lesser values are abnormal, higher values are also abnormal. But when you look at lung function, the higher values, for example, if you take spirometry, anything more than 100%, you would not call it as abnormal. You would still call it under the normal category. So what people started doing is they removed the right half of the 2.5% and fitted that with the 5% error that may happen on the left hand side. So this 5% or the fifth percentile that has a z-score of minus 1.645 standard deviation was called as a lower limit of normal. And if your values were less than the z-score, you would then call it abnormal. So these were then developed for the spirometry parameters such as FVC, FEV1, the ratio between FEV1 and FVC, and X5, because X5 is on the left-hand side. Those parameters where you would call that values above something is abnormal, like for example, R5 or R19 or AX and so on, then you remove the left-hand side, you consider all the left-hand side as normal, and then shift the 5% to the right-hand side, and then call that as the upper limit of normal. And you would then use those criteria to differentiate between normal and abnormal. Now, mind you that in this approach, you are not considering the abnormal population's pattern at all. This is just a statistical cutoff to define what is likely to be abnormal. What would be ideal is to collect data from the unhealthy population as well and see where it lies as compared to the healthy population. So here is a classical healthy population on the left-hand side, which we would call as true negative, and the disease population on the right-hand side, for example, asthma, COPD, which we would call as true positive, and the left one is true negative. And then the midpoint of that would what we would call as cutoff value. Now, ideally, if you get a test like this that has a very, very good cutoff value with 100% sensitivity and 100% specificity, you would be a very, very lucky person. In real life, this does not happen. The shape of these two curves is what I've just shown over here. So the true negatives on the left, the true positives on the right, and there is a significant amount of overlap. The midpoint of this overlap is what we would consider as the cutoff value, but this would also give you false positives and false negatives, but we would live with that. And based on this cutoff value, you would decide the sensitivity, specificity, the positive predicted value, negative predicted value, and so on. Now, compared to the statistically derived portion on the top, I believe that a cutoff value is more scientifically robust in differentiating between normal and abnormal. So if you look at historically how the FEV1 upon FVC ratio, which we know is a very good parameter to differentiate between healthy and obstructive airway disease, what are the parameters and what criteria were used right from the beginning? So starting from 1959, ratio less than 0.7 was considered to be the cutoff value. Then it was adopted by the ATS, but with a cutoff value of 0.75. And subsequently, you see how it has changed over a period of time. The gold adopted the less than 0.7 post-bronchodilator ratio, and they still continue to adopt the fixed ratio as a better indicator of defining COPD. Others seem to have taken the other route of using the lower limit of normal. The ATS ERS in 2005 recommended that we should not use the fixed ratio, we should use the lower limit of normal. And subsequently, a lot of other well-renowned people also started using the lower limits of normal as the defining criteria for COPD. In 2019, Surya Bhatt from Birmingham in the United States actually published a very interesting paper. 10,000 smokers followed over a period of time, defining COPD either with the fixed ratio or the low limit of normal. And then over a period of time, finding out what the clinical outcomes, how many of them needed to be hospitalized for an acute exacerbation, and then going backwards and saying, oh, the fixed ratio was better or the low limit of normal was better. And what he ended up saying was the fixed ratio was as good, if not better than the low limit of normal. And this is a table that he published in the JAMA in 2019. Look at the ratio thresholds and the corresponding sensitivity and specificity. So if you use a fixed ratio of 0.7, the sensitivity was 0.66 and a specificity of 0.79 to pick up those COPD patients who would then get admitted for an acute exacerbation of COPD. But look at the lower limit of normal. The sensitivity was only 0.49, but a little better specificity than the fixed ratio. So is it possible that the low limit of normal is less sensitive in picking up the diseased population? And this is exactly what was addressed in this very interesting study published more than a decade ago. Which one is better, gold, that is the fixed ratio, or is it the lower limit of normal that should be used in defining COPD? This was a very interesting approach that they used. 405 doctor diagnosed COPD patients, and these were diagnosed by experts. So that was considered to be a gold standard. And then they compared the fixed ratio versus the low limit of normal with a Z-score of less than minus 1.645 standard deviation to do a head-to-head comparison between these two criteria. And this is what they observed. The fixed ratio or the gold criteria misdiagnosed 28% of the cases, and they were actually false positive. So they were overdiagnosing more cases of COPD. But on the other hand, when you use low limits of normal, and here they use three different equations that were published in the literature to define what the low limit of normal should be. And you can see that all the three low limit of normal criteria showed misdiagnosis in around 40 to 45%. And this was false negative. So they were underdiagnosing COPD. Now, this was believed to be this was interpreted by the experts as, oh, gold is overdiagnosing, and therefore we should stop using the fixed ratio. Low limits of normal, I think this is better, although the evidence suggested that they were underdiagnosing more cases than what the fixed ratio was overdiagnosing. And I believe that the people who were supporting the low limits of normals, they had a bigger voice, and therefore the world started accepting that no, we should start using the low limits of normal. Now, what this could end up is there could be concordance at the lower end. So both FEV1 upon FVC is no COPD, FEV1 upon FVC, LLN showing no COPD on the left-hand side, and concordance on the right-hand side where both of them are showing presence of COPD. But what about the middle part, where the fixed ratio is picking up COPD, but the low limit of normal is not picking up COPD? Now, what should we do over here? Is it the fixed ratio that is overdiagnosing, or is it the low limit of normal which is underdiagnosing? And this issue was addressed very recently in a very interesting paper. So COPD patients from two cohorts, one was the board cohort of 360 diagnosed COPD cases, and the chain cohort of 722 diagnosed cases. This is from Belgium. They were enrolled and followed over a period of 7 years. So during the 7 years, what happened to these patients in terms of hospitalization, in terms of death? This was directly, sorry, hello. This was directly compared with fixed ratio diagnosed versus what if they had used the GLI Z scores to define COPD using the low limits of normal. So here is again a head-to-head comparison between the fixed ratio and the low limit of normal with a clinically relevant endpoint. And this is what they found. In patients where COPD was picked up on fixed ratio, but not on the low limit of normal, 18% from the board and 15% from the chain cohorts, they did not meet the GLI criteria. Now, this is despite these patients having significant symptoms, hospitalizations, and increased mortality. More interestingly, GLI Z score underdiagnosed 45% of emphysema that was picked up on gold. And here are the results. So you can see the chain cohort and the board cohort with the FEV1 upon FVC Z scores. They're all less than minus 1.645, which is a fifth percentile. FE1 upon FVC ratios are less than 0.7 as expected because this was defined on post bronchodilator FE1 upon FVC. But look at their FEV1 percentages, FVC percentages, proportion of prisms, breathlessness on the Modified Medical Research Council score, mortality 20% and 33%. So what LLN, what the lower limit of normal called normal, they actually had more mortality and they had more exacerbations in the last 1 year. Now this started questioning the authenticity and the value of the lower limit of normal. I was fascinated to see this figure that was published very recently in BMC Pulmonary Medicine. What is the FE1 upon FVC ratio? Is it normally distributed? And you can see in this very large study of the enhanced study, more than 25,000 people, it is clearly not normally distributed. FEV1 upon FVC is not normally distributed. It is skewed to the left, as you can see here. Now, if the data is skewed to the left, now see what happens with the red line on the right, which is a fixed cutoff of 0.7. The Z score of the fifth percentile will obviously go towards the left because this data is skewed towards the left, which means that if you use the lower limit of normal in a left skewed data population, your cutoff value is going to be very low. In the sense, it will be somewhere around 0.6. So you will call people abnormal or having COPD only if their FEV1 upon FVC ratio is less than 0.6, which is your lower limit of normal. And this is obviously going to underdiagnose a large number of patients. So the lower limit of normal for FEV1 upon FVC, from a scientific point of view, showing this data clearly has the ability to underdiagnose COPD, and that I've just shown you that data. Now, this is a study that was just published last month. Very interesting gold data. Patients of COPD diagnosed on fixed ratio and then followed up over a period of more than 8 years with clinically relevant endpoints. And the question that they asked was, which Z score would have been optimal to predict chronic airflow obstruction based on the clinical outcomes during the 8.4 years? And look at what they found. That the percentile of the FEV1 upon FVC ratio, the pre-bronchodilator, the ideal Z score should be minus 1.336. That is the ninth percentile, not the fifth percentile. And you can see the percentiles for the post-bronchodilator FEV1 upon FVC ratio, FEF 25 to 75, and so on. So the results suggest that the current low limit of normal of FEV1 upon FVC, which is equivalent to the fifth percentile, may fail to identify all those with the disease. So the recommendation that the authors have made is we should not use the fifth percentile low limit of normal. We should shift it to the right. Use the 10th percentile for the low limit of normal. And that would probably that would be a more ideal low limit of normal for FEV1 upon FVC ratio. Now, what I learned from this was if your data is skewed towards the left, the Z score gives you a big problem. And here I'm just showing you how a normal distribution looks like versus a right skewed data this time, because I want to now show you results of the oscillometry. If the data is normally distributed, the mean, median, and mode are right in the middle. And you can see the standard deviations. 1.645 is the standard deviation. So that's the fifth percentile on the right-hand side. Now, if your data is skewed to the right, the median shifts to the right and the mean even shifts further towards the right. Now, when the mean shifts further towards the right, the standard deviations go further towards the right. And this means that if you use the low limits of normal or the Z score of plus 1.645 or the upper limit of normal, that would be a much greater value because of the skewed data. I was looking at the eosinophil data, and this is a big global study with more than 76,000 people across the world. Blood eosinophil is a right skewed data. It is not normally distributed. And the reason why I was excited with this, because all oscillometry indices, excepting X5, is right skewed data. So we did a nationwide study with 3,680 people, looked at the blood eosinophil counts, healthy asthma, COPD. And then when we compared the medians, you can see that healthy median was 230, asthma was 380 and COPD was 270. Something that we would relate to say what is normal eosinophil count and what is abnormal eosinophil count. But if you see all the data, this seems to be heavily skewed towards the right. Now, what we did was, so we dug out that data and drew the distribution of the eosinophil counts. And clearly you can see that the blood eosinophil count in the healthy population is grossly skewed towards the right. You can see that the median is further to the right. The mean is further to the right than the median, and that confirms the right skewed data. Now, if you take a Z-score of this and not the median, which is the 5th percentile on the right-hand side, the value comes out to be 696, which means that if you use a Z-score to define what is an abnormal blood eosinophil count, then you would say that it has to be around 700, not the 300 that we are well versed with. Now, people will say, oh, that is because it's not normally distributed. So you log transform it and you normally distribute it. So you get a normal distribution. We log transform the data. And then when we looked at the log transformed Z-score data for the 5th percentile, it got even more worse. So instead of 696, it went ahead to 708. Now, with this background, we also we also looked at AX values.
Sandeep, do you have much more? We're
Yeah, I'll just finish it in just 1 minute. 1 minute.
Okay.
Yeah, so AX is right skewed data. When we look at the Z-score for our Indian population, the Z-score comes out to be 17.4 AX. We log transform it, make it normal distribution, and the Z-score becomes even more worse. It increases to 20. So if you use a Z-score or the low limit of normal in an Indian population to define what should be the cutoff value for AX, it would be 20. Only values more than 20 would be picked up as abnormal. The same thing happens for R5. This is the Z-score because it's a right skewed data, log transform it, normally distributed, and the Z-score becomes even worse. So the lessons that I learned are statistical limits of normal do not necessarily separate disease from health. All oscillometry data are not normally distributed, left skewed or right skewed. Z-scores increase the cutoff value significantly, and this is responsible for underdiagnosis. And contrary to popular belief, log transformation can often increase, not decrease the variability of data, whether or not there are outliers. So I believe that fixed cutoff values instead of Z-scores is a more scientific way to differentiate between healthy and disease states. And this is a very interesting article that showcases how log transform data actually makes your analysis worse than what you actually wanted it to happen. And I would stop over here. I would like to thank Sapna, who is a statistician in a way. She was my mentor in teaching me how statistics should be used in defining what is normal and abnormal. Disha, who just presented before me, who heads the ARISE network, and the wonderful ARISE team that I have here in India. Sorry, I went over time, but that was the argument that I wanted to make. Thank you so much.
Five minutes?
Yeah, no, let's go five.
Let's go five. Very important topic.
Yeah.
I'd like to hear what people want to, so Jason is out of the gate here.
Yeah. Thanks very much for that thoughtful presentation. I'd like to give a different take on it, however. I don't think you're going to get where you need to go by playing around with the cutoff values. And I think actually your data show that. Because if you do that, all you're doing is trading off false positives for false negatives. The problem with oscillometry versus spirometry, when you do baseline measurements, comes down to the fact that if you want to understand how a system works, you have to kick the tires to find out. For example, you would be unwise to propose marriage to someone who all you've done is gone out on a whole bunch of nice dates. You want to go camping with this person. You want to see how they respond under stressful situations. Now, when you do oscillometry under baseline conditions, all you're doing is a little minor perturbation to the lung. And that's all the information you get. When you do spirometry, you're doing a major perturbation, taking a big breath, you're blowing out as hard as you can. So to take asthma, for example, it doesn't surprise me at all that baseline oscillometry is not as sensitive to asthma as baseline spirometry under baseline conditions. On the other hand, if you stress the system with a methacholine, now the stress is the methacholine, not the oscillometry. Usually using the oscillometry as a probe. I don't know what the equivalent is in COPD, but that I believe is the fundamental reason why oscillometry is under baseline conditions, not as sensitive as spirometry. You need to give the system more of a kick to find out how it works. So that's it.
You can talk about it.
Okay, I will add to James' comment before I go to Ron. You can find a cutoff in oscillometry that will match spirometry if you really want to, and it will have the same sensitivity if you just want to accept so many false negatives. In other words, you're trading off, as he said, specificity, right? So if I want to be sensitive as a screening tool with oscillometry, you can actually make it with the same comfort of the sensitivity that you have with FEV1 over FEC is 0.7. And your points are well taken that, and the graphs show that if I just move on that graph of where the 95% cutoff is to where the 0.7 is, it's not a 95%. It's I forget the exact number, 9% if I remember, so 91% cutoff. But it's not technically, there is a problem with people who are setting up Z scores and using log transform when log transforms aren't the right transform. They're grabbing the easy one. There are many people in the most recent study, I forget, you talked about this exponential one. They obviously chose a different transform to make the curves normal, because if I want to use Z scores appropriately, I really have to have a normal distribution after my transformation. If I don't, I shouldn't just keep on going and say and stick with the new Z scores. It's a mistake to do that. And unfortunately, a large part of many fields do this exact same problem. And so there's a bigger problem to solve out there, not just oscillometry versus field. Okay.
This is David Kaminsky. Thank you very much. It was really thought-provoking, and I'm going to be thinking about this some more. But I think one of the fundamental problems is all of the arguments you made about COPD are using COPD as the gold standard based on clinical diagnosis, which I agree with. But if you're using cutoffs to detect disease in a screening mode, let's say, you're going to end up with too many false positives on the older end of the spectrum, and likewise, too many false negatives in younger people for obstructive lung disease, and that has certain consequences too. So I wonder if the best compromise is really to say, if you're interested in diagnosing COPD, perhaps indeed the 0.7 cutoff is the better way to go. But if you're interested in diagnosing why someone is short of breath, you might take the lower limit as your first stab at whether or not there's obstructive lung disease, and then go from there.
Great thought. Absolutely. I agree with that.
Okay. Charlie.
Wonderful presentation, and I agree with David and that this is very thought-provoking. I'd have two comments. One is, too often we treat disease as sort of a one-size-fits-all, where the effect on the lung is uniform, that from the trachea right down to the peripheral part of the lung, it's all being affected the same. And that's clearly not the case. There are people with asthma, for instance, that have central airway lesions. They present as asthma, they're treated as asthma. Same thing with COPD. And we forget that when you start to hyperinflate in response to COPD, that's going to change airways resistance. And so that's going to decrease its sensitivity in that particular situation. The second thing is that, as we discussed a little bit yesterday, using a single measurement to determine whether or not a person does or does not have disease is not what happens clinically. We think about all sorts of things, symptoms, how they respond to bronchodilators or not, or how their occupational exposures. And so I think things like aggregate endpoints, like the BODE index, or a lot of these wonderful questionnaires that measure different aspects of what's going on in the lung. And then together, we bring them together and say, does the person have disease or not? And if they do have disease, how bad is it? And we don't do that with one single measurement, because the lung's too complicated and the disease process is too complicated. But I loved your analysis. I think it's wonderful, and it really made me think about, the importance of skewed data. Thank you very much.
Thank you. Thank you. Thank you.
There might be one online.
There's one online comment.
Go mine.
It disappeared, actually.
Oh, okay. The Bronx, you didn't have anything to say? Then move on.
Okay. I think-
Frans
He
Jong,
doesn't-
Netherlands. Indeed, I put in the chat that, as you know, I'm connected to the ERS, that definitions of diseases do change. And for instance, for asthma, we always used 12% of baseline is reversibility. And now in the last ERS ATS consensus of 2021, we stated 10% change from the predicted values. And there is already a lot stated about indeed over that you see that in older patients you will have an overdiagnosis, in younger patients you will have an underdiagnosis. We are in discussion with the SERS, with the GOLD and the GINA community, but there is also a lot of money involved in that, and that would make it even more, let's say, disputable or contradictory. So I will not go into that field, but I think we will come into some consensus into the future. But thank you for this very interesting talk.
Thank you.
Okay.
Thank you. Thank you so much.
Excellent. So I'd like to thank Sandeep, and I'd like to move on. Thank you very much. Okay, Eric. We'll set you up here. Where are you? No, that's not yours. Yes. I did have it up there? Oh, that was the one. Okay. Very sorry. Okay, it was just one, the first slide. There you go. No, there we go. You want the cursor? There you go.
Sharing the screen?
We are not sharing. Just a second. Zoom.
Oh, it's on, yeah. So put it into.
Oh, I have to zoom and share. This one.
There, yeah.
So there. This one. There.
Just make sure it's in presentation mode with the chairman.
So do this one.
But
I
actually,
could
we
swap
did
it.
swap it, yeah. Yeah, and here, here,
It's actually good.
Appreciate it.
Yeah, there you go.
Yeah, hi. Again, I'm Eric Garshik from Boston. I work at the Veterans Affairs Hospital.
Just keep talking, talk around.
Oh, okay, and I want to thank very much for being invited back to attend the conference. It's been great. I've learned a lot. And I think if I can summarize some of the themes of what I've heard so far, one is what is abnormal? How do you define that? And how does oscillometry and spirometry compare to picking out an abnormal population? So I think my talk fits very well into those themes. Just wait until we get the next slide up there.
That should be it.
We're good?
I think we got
Okay,
it.
and I'll just use this to,
Yes.
Perfect.
okay. And just, and how do I advance it then?
Oh,
Does-
the arrow down key on the keyboard.
Here, well, yeah, it didn't,
Or the space bar, just.
space- okay. Yeah, it didn't do it. Yeah, it didn't do it.
And then we should be okay.
Okay, so yeah, just some disclosures. Most of my research now deals with the effects of deployment in veterans, and I have some grants from the Department of Veteran Affairs and some royalties from Up to Date for spinal cord injury pages. So we became concerned at the Veterans Affairs Hospital when veterans started coming back from deployment to Iraq and Afghanistan with respiratory symptoms. And the type of exposures they had were, this is a part of the world where there were many, many dust storms. This is a picture of a dust storm over a base, burn pits where garbage got burned, everything got burned, computers, human waste, file cabinets, and you can't call the garbage removal guy to come and take your garbage away. You burned everything. Of course, engine exhaust, other combustion sources due to combat, and of course, occupational exposures at the base, military occupational exposures. So we were faced with veterans returning with low respiratory symptoms, and what could they have, and what are the pulmonary function testing was typically in the normal range. And so we asked a question in this research, are there associations between respiratory symptoms and pulmonary functions, spirometry and oscillometry that might guide diagnosis and care? So I'm a study chair of this VA cooperative study where we're collecting data at 6 VA sites around the country, recruiting people just based on deployment and not based on symptoms. And it really is representative of the deployment. The veterans had land-based deployments, both to these at the exposures. We selected them from the Department of Defense roster. They lived within 25 miles of six hospitals around the country. And at 4 sites, we called them back for additional testing: Boston, Houston, Minneapolis, and Seattle. And we called them back with about respiratory symptoms. We took back people who had minimal smoking history, never smoked, or they had recovered from COVID, they didn't have severe COVID. And, we asked the question of does oscillometry have anything to offer, or spirometry in terms of associations with symptoms? So we defined symptoms very carefully using a respiratory health questionnaire at both visits. Shortness of breath on level ground or walking up a slight hill, chronic cough in most days for 3 consecutive months of the year, and wheeze in the last 12 months. You had wheezing, whistling in your chest at any time. So these are fairly standard questions. Asthma was defined as healthcare provider diagnosed asthma. And we did oscillation technique with Resmon using the ERS standards. We used Osteen predicted values, but actually in the data I'm presenting, I'm not going to showing those. I will say that it didn't matter how we analyzed the data, the predicted values gave the same results as the raw data oscillometry, adjusted for age, height, and BMI and sex. We did spirometry using ATS standards and used the global predictives. So here's what we got. And this is the total cohort's going to be actually ultimately around 300. This is the first 126 people. And we divided the people who never had symptoms, they had symptoms at study visit 1, but not at study visit 2. They remitted. Persistent symptoms, so study visit 1 and 2, meaning the previous visit was about 4 years earlier in the main study, we called them back. So about half the people had persistent symptoms, half had remitted, and then other people who had no symptoms in the first study, 14 or 70% had new onset symptoms defined using that respiratory health questionnaire. Most were male here, but you can see actually the prevalence of males drops off the new onset symptoms here, suggesting that more women may have had new onset symptoms or persistent symptoms. The age, so they're very young, still in their 40s. The minimum pack year is about 1 pack year, but this is very few had past cigarette use. They were seen 4 years earlier. The deployment, they were about 14 to 15 years post end of deployment. The deployment typically lasts around a year. And, some had more, some had less, but I guess this is the question: can exposure to high levels of pollution for about a year cause anything persistent? I mean, it's kind of, it's a very different model of pollution than we're used to seeing, chronic pollution versus acute episodes. So this is kind of it's not World Trade Center acute episode, right? This is chronic exposure about a year to a year and a half or so. Now, in terms of healthcare provider diagnosed asthma, it's kind of interesting. So 3 people without symptoms were diagnosed with asthma before deployment or during a post-deployment. You see most of the asthma got diagnosed in people with the persistent or new onset symptoms sort of during a post-deployment. So suggesting they went through their healthcare provider and this was the diagnosis. There's a bit of concern about a dyspnea post-deployment, but in fact, most of these people had wheeze and chronic cough as compared to significant dyspnea. And then inhaler use, most of the therapy were given in people with persistent new onset symptoms, having said use an inhaler in the past 12 months. So regarding spirometry measures, let me take you through this. And this is never symptoms, remission compared to never. And we combine persistent new onset due to relatively small numbers here. So there's no difference in percent predicted FVC with new onset symptoms, with people with never versus new onset of remission, P.18 with the small numbers, but, slightly lower, but really no major difference. But the ratio actually, and this kind of tells you about the importance of having a comparison population, even though the ratio is 94% versus 97%, it wasn't significant, so it was lower. There's a small signal there in people with respiratory symptoms. And then the bronchodilator testing, this is just 2 puffs of albuterol. This went up a little bit. This didn't really change, went down a bit, in fact, so 0.03. And then this is the percent change relative to the predicted value, the way it's now defined to do. So a slight, little more of a bronchodilator response in people with symptoms and without symptoms, they'd be hard to pick up clinically, of course, in terms of looking at 4.6% improvement. Now, what about the oscillometry? And so I think kind of a busy slide, as most oscillometry slides are, I guess. And this is the raw data from the Resmon, adjusted for age, height, sex, BMI, and site. And so you can see that the R5 is kind of similar here, but maybe a little higher. The R19, similar, this compared to this, not significant, but maybe a little higher. This actually is a little lower, but kind of in the right direction. R5 minus 19, a much noisier measure, a little higher, but no significant difference. The AX, is a little higher, and the resonant frequency, no real difference. So maybe some subtle abnormalities, not significant, but post-bronchodilator, it's kind of interesting, even though these don't meet the criteria for a classic bronchodilator change, it's, 11% drop in the R5, 9% drop for borderline significant, R5 minus 19, kind of in the right direction. X5, it gets less negative right here. X5, AX, improves, and FRES improves. So in fact, so it looks like the bronchodilator signal in folks who have persistent new onset respiratory symptoms, despite not all being diagnosed with asthma. And then finally, if you look at just the people with diagnosed asthma in the veterans versus no asthma, this gets into the issue of subtle abnormalities of the small airways in asthmatics. But actually, you pick up the same thing in his asthma, non-asthma. So even though, the ratio is slightly lower, spirometry picks that up. The X5 is a little lower here in asthma, and the resonant frequency and AX are a little higher. So these smaller airway abnormalities or differences, I'll say, in asthma and non-asthma. So what do we say about this? To summarize it all, in veterans, 15 years post-deployment with new or onset persistent symptoms, wheeze and cough are most common. The symptoms are associated with asthma diagnosed by a healthcare provider. And if you have new or persistent symptoms, there are subtle abnormalities in the spirometry and in oscillometry with a small bronchodilator response. It does not meet the significant. And then there's evidence of some small airway dysfunction or differences, I'll say. I'm not sure what dysfunction means, but differences in the asthmatics. So what does this mean clinically? So I think that unrecognized or undertreated asthma may be a cause of symptoms in post-deployment veterans, despite largely normal pulmonary function. And as clinicians, we face this all the time. And somebody who's got symptoms, it may get a little better, the bronchodilator, you don't pick up a big abnormality. But looking as a group, there is a bronchodilator change. So maybe we should hang in there along with that diagnosis. Alternatively, doctors like to diagnose conditions, and if you're short of breath, let's call you asthma, maybe there's a slight improvement. So I'm not sure what the default diagnosis is, but I do know that, it seems like small responses to bronchodilator may be meaningful, and we're not seeing major abnormalities here in this young cohort using oscillometry or spirometry. What we're doing in terms of our larger study is now adding a longitudinal component to it to try to, what are these subtle changes mean long-term in terms of developing chronic lung disease in their 60s or 70s. And I just want to thank my colleague. We actually worked with an occupational medicine resident who was in the Navy, who's back in Okinawa now with his family, and my colleagues at other VA medical centers, Paul Plank, Emily Wan, Chris Wendt, Farah in Baylor, and Victor in Puget Sound. So let me end here and thank you very much.
Good. Are there any questions? I have a question, or a comment as well as a question. So you show that there was a significant bronchodilator response with the oscillometry in patients exposed.
Compared to, well, they're all exposed.
Yeah,
These are people with
that's right.
symptoms.
Yeah,
And a small difference compared to people without symptoms.
I see. I see.
Okay, right. So we don't have an unexposed group here.
Right, right. It would also be interesting in the Boosting study that we use for reference values all the time. They also did bronchodilator response, and they found a normal value for the bronchodilator response, which was 12% for resistance. But for reactance, I recall the number being very, very small. So I think what you have is a very comparable to normal bronchodilator response for resistance, but a much larger bronchodilator response to reactance than would be expected in a normal population.
Oh, interesting.
Yeah.
Interesting in terms of the changes here, right?
Those if I recall it correctly.
Okay, I have
Those
to
are
look.
larger than what was found. I don't know, and I think in other studies, it's always true that the reactance barely changes at all in response to bronchodilator in healthy adults.
Well, it wouldn't be expected to, because the response to bronchodilator in a normal person is the reversibility of vagal tone. And since that innervates the big airways, you would expect to see it in the R and not in the A.
So there's a potential story on the reactance.
Okay.
Look at the what's expected in healthy.
Yeah, that's a great point.
So
Thank you,
this is
thank you.
one of these negative studies that sort of, I mean, in a sense,
This?
that drives you crazy.
You think this is negative?
Good response. Next question.
RC, we've made a cottage industry out of publishing negative studies. Negative studies are just as important.
Right.
So these are soldiers, military people that present
Yeah,
with
veterans, yeah.
with persistent symptoms.
Well, so, right, these people, so they get, the initial cohort
Yeah,
got recruited. This is going to be 5,000 eventually coming in,
Right.
just recruited based on deployment.
right.
So they're all exposed, and we're actually recreating their their exposures using satellite imaging. We have a questionnaire.
Oh, cool.
So I didn't put an exposure side to this because
Yeah.
of the small number, but they're all exposed to something over there. There's no doubt.
Right.
And so we're going to ultimately looking at a little bit versus high exposure and
Right,
these outcomes. But the question is, not everybody gets sick. There are some people that are just fine.
right.
And so in defining symptoms objectively using our questionnaire, are you picking up some early abnormalities or, that?
Well, I've had
might
friends
get you-
deployed over there,
Right,
and not all of them get exposed because they're working in offices, whatnot, and, conditioned air. Then there's the issue of the healthy worker effect, that people who do get exposed and are very symptomatic will get rotated out of that, because I've seen that happen. And then you have, like, what are they doing? What's their job? So we use this in Hard Rock Miner.
yeah.
The guys who are at the face of the crusher are the ones that get silicosis and restrictive lung disease. But if they're driving trucks around hauling stuff, then not so much because they're exposure. But I'm wondering about other aspects of them, like they're actually, like Jason was pointing out, that it's when you tweak the system. So what's their exercise performance? Because these guys get tested periodically.
Well, they're all veterans now. They're not.
Oh, okay.
You've got, the veterans, they're retired they're out of the service.
Right.
At least they're not active duty. They
Right,
could still be in the reserves. So we don't have exercise capacity. We do have a dyspnea question, right?
right,
And about 20% said yes to that.
right.
The people with symptoms, so they do have some dyspnea. regarding to the office workers over there, I mean, there are dust storms all over. I mean,
Right.
I'm not, maybe some few air conditioned offices, you know, in downtown Baghdad, but you know, these are the area, the very dirty, dusty part of the world, even if you're working inside during the day, you know, in an office. But you're right. I mean, we do want to ultimately relate this to exposure amount, and we do have an exposure questionnaire that gets those sort of that 5 categories I put up of exposure is a different dust storms exposure. So we're actually, you know, using that to get at that. Plus, we're using satellite AOD value imaging to look at large and small particles in the atmosphere based on where they were deployed.
Yeah, that's cool.
So that's coming up.
That'll be
But I would say this is not totally a negative study. I mean, I think that the fact that symptoms we perturb the system by giving a bronchodilator, perhaps, you know, and there is a signal here, you know, and they're very young. They're not really sick. Yeah.
David,
So that's my comment exactly. I think you do have a signal because defining a bronchodilator response is always based on a healthy population, looking at something beyond the standard deviation of the response in healthy people who aren't thought to have airways disease. But Hansen, many years ago, suggested we're defining it all wrong. We should define it based on each individual's own standard deviation of their baseline measurement. So for example, you do 3 baseline spirometries, you look at the coefficient of variation. If they have a bronchodilator response beyond the coefficient of variation, that might be a bronchodilator response statistically granted.
Okay.
But it may be meaningful to that individual. If you look at your data here, all your p-values that are near significance are because that change is beyond 2 or 3 standard deviations of their baseline value. I'm looking at the never group as the baseline, I guess. But so in other words, in this population,
yeah,
this may be significant.
Right.
Even though it might not be considered significant for a general population.
Right.
You're right, David, because I mean, all the baseline values here are actually look pretty normal, right? In terms of PX and resistance and whatnot. Yeah.
By group, I'd say
Yeah,
there's,
by group,
you know,
yes.
looking at the OSPIN predicteds, which, you know, you get some very high numbers there, predicteds, or it's a little, it comes out about the same, but about 9% of the population were abnormal using OSPIN predicteds. But certainly nearly all are normal.
Yeah.
Normal, right? Whatever that means.
No, but it's interesting that people complain about problems, right? Despite being relatively normal.
Yeah,
No
that's
matter how
right. And I think, you know, so what I've done clinically in my clinic at the DA when I see patients is, and they give a history of that suggestive asthma, despite normal VOTs. I hang in there with inhaled corticosteroids and, you know, put them on smart therapy and.
Asthma can be so variable. They could be good one day and bad next day, depending on when they show up in your clinic.
Right.
You know, yeah.
good points, good points.
Do you peak flow them at all? Do they monitor at home?
No, I don't. I would say that given this, I never thought of that actually, coming that. But I would say, given the small changes we're seeing, maybe you're saying for home monitoring, just do it. Maybe I should start to do that.
Yeah, it's cheap, easy. And
Just look
we'll
at
have-
variability.
I should start to do that. Yeah, I have.
The power of your study is all the different groups and comparison between the groups. That's where the real power.
Thank you. Yeah, no, well, thank you very much, everybody. And I do think it fits in the theme of like what's normal, right? What is normal?
Okay, thank you very much. Move to our last speaker before coffee, I believe, Dr. Ramon Ferre. Two speakers do we have? Or Zoltan is just saying hello. Okay. Ramon, can you share your screen?
Yes, can you see my screen?
Yes, but not the presentation mode. Can you do presentation mode, please?
Now?
Yeah.
Yes,
Yay.
excellent.
Okay, so thank you very much, Ron, for inviting me to give this lecture or this presentation. And first of all, good morning or good afternoon or good evening to everybody. This presentation will go back to theoretical basis, not clinical application, but I will provide not new content, but some kind of reminder, if you like, for people which are not from bioengineering background, but more clinical background. Perhaps it can be interesting to remind this. This content has been recently published in cooperation with Raffaele Della Ca in 2 months ago in an ERS monography. So I will talk about the difficulty of measuring respiratory mechanics during spontaneous breathing, provide some ideas on the principle of oscillometry, also some theoretical aspects of application of oscillometry, and on the interpretation of oscillometry data. Measuring the respiratory mechanics in spontaneous breathing is not possible in a non-invasive way if we don't use any external appliance. For instance, you can see here that if we characterize the flow, the respiratory flow, and the change of volume that can be computed by measuring flow at the airway opening, and also the force exerted by the inspiratory muscles, if we consider it in a simplified way that the respiratory system is a elastic and a resistive component, this is the mechanical, most classical presentation. It's not the most usual. Perhaps in the field of oscillometry, it's more usual this kind of analysis, thinking about the pressure applied by the inspiratory muscles and the resistance and the compliance of the system. Anyway, it's not possible to measure the force or the pressure exerted by the inspiratory muscles. So it's not possible to measure resistance and compliance only from the signals provided by the patient. We need something external. There is, in fact, an alternative. It could be possible to introduce an esophageal balloon and then to estimate pleural pressure to compute lung resistance and compliance. But of course, this is not for routine because it is invasive. So this is the conventional setting of oscillometry that everybody knows. And we have a pneumotachograph that measures the addition of the signal provided by the force and oscillation generator and the signal provided by the breathing from the patient. I'm sorry. So we are measuring with the devices, we are measuring the flow and the pressure, which is the simultaneous action of 2 generators. One generator is the forced oscillation device that provides an oscillatory signal acting on the impedance of the respiratory system of the patient. But at the same time, there is another active generator, which is measuring, in fact, the impedance of the forced oscillation device, of course, at the frequencies where the patient is breathing. So the pressure generated by the oscillometry device is the product of the impedance of the patient times the flow measured, the flow generated by the oscillator. This is the principle of oscillometry. But at the same time, we have to take into account that there is also a component of the pressure which is caused by the respiratory breathing against the impedance of the device. If we combine these equations, we can see that the impedance that is measured from the recorded signals is not exactly the impedance of the respiratory system. You can see here that what we measure is respiratory impedance of the patient with some bias that depends on key, which is the equation between the component of the spontaneous breathing at the frequency of interest divided by the flow generated by the impedance device, by the forced oscillation device. So unless this term is 0, we have a biased estimation. So in case that this is 0, which for instance at very high frequencies, we have that the impedance measured coincides with the impedance of the respiratory system. The problem is that the lowest oscillatory frequencies, where there can be some components of the oscillatory, some components of the spontaneous breathing. That's why at very low frequencies, at the lowest limit of frequencies of oscillometry, we can have some problems if we are not sure that there is no problem with noise. Another important question on the application of oscillometry is the oscillation signal that we use. The most optimal signal from the point of view of the signal-to-noise ratio is the sinusoidal or the monofrequency, because all the energy of the signal is concentrated in one frequency. In fact, this kind of signal was the one originally applied in the 50s of the last century when the technique of oscillometry was developed. The only problem with this signal is that if we want to get information at several frequencies, the measurements can take longer because we have to measure subsequently the different frequencies, and also the results then that we obtain are not simultaneous. So we are getting results of resistance and reactance which are not measured simultaneously. The signal that is probably the best, in my opinion, is the composition of several oscillatory components. We can have, as in this example, a combination of different frequencies, in that case, the same amplitude for each component. The advantage of this signal is that we can customize the relative amplitudes to improve the signal-to-noise ratio. For instance, we can improve the amplitude at the lowest frequencies to avoid or to reduce the potential problem of the signal-to-noise ratio that I mentioned before. We also can optimize the combination of relative phases of the sinusoids to improve the ratio between the energy and the amplitude of the signals. And finally, we can select whatever frequencies we want. For instance, selecting non-sum, non-difference frequencies to avoid crosstalk in case of nonlinearities. And there is also another signal, which is a series of impulses, which is impulse oscillometry commercially. Here, the signal also provides several frequencies simultaneously. You can see here the spectrum of these impulse trends. But this signal is suboptimal in terms of energy versus amplitude. You can see that it requires double amplitude than here to have a smaller amount of energy at different frequencies. The amplitudes of each component of frequency cannot be customized, so cannot be used to improve signal-to-noise ratio. And also there is no optimization in the phases of the different frequencies, because this composition comes from the definition of the impulse. And also frequencies cannot be selected to arise control. So it seems, or at least in my opinion, the impulse signal is the worst that can be used to measure respiratory impedance. What about signal measurement? Sorry, can you hear me?
Yeah. Sorry, just
Another point is signal measurement, and this sometimes is not explicitly mentioned, but I think that is important, perhaps to understand several differences we observe when comparing devices. The pressure that is measured is not the actual pressure, is the result of measuring the pressure with a transducer that has a given frequency response. So the pressure we measure is the result of multiplying the actual pressure times the frequency response of the pressure transducer. And similarly, the flow signal we measure is the result of using the frequency response of the pressure transducers used to measure the differential pressure times the impedance of the pneumotachograph. So this is the relationship between the actual flow and the flow that we measure. So if we compute impedance as the quotient between the measured pressure, which is what we have to do for sure, then we have this expression when we see that there is only equal value between the impedance of the patient and the impedance we measure only if this term is 1. So it means that we have either to design very well the device, combining the frequency responses and the pneumotachograph frequency response, or to compensate for this value digitally. Okay, so any way is possible. But if this is not done carefully, it could result in different tendencies on the frequency dependence of the results. So perhaps it could be that differences observed when comparing different devices could be with analogs, could be in part perhaps due to a bad balance or a bad correction of these characteristics of the sensors. Just a comment about signal processing. In principle, the theoretical background of oscillometry requires that the system to be measured, in that case the respiratory system, is linear and stationary. But we know from classical physiology that this doesn't happen even in normal subjects, when we know that the resistance of the airways depends on lung volume, and also the compliance of the lung depends on lung volume, and also when we have a regime which is not linear, we can have a resistance which is flow dependent. In case of a linear system, we have here that, for instance, even in that phase having inspiratory or expiratory flow or at different points of volume, we have that if the system is linear and stationary and we compute the impedance cycle by cycle, we found that it is constant as expected. These dependencies of volume, flow, etc. is minor. The effect is minor in healthy subjects breathing at an FRC. That's why it's usually normal and reasonable to measure the mean impedance along the breathing cycle in the case of normal subjects breathing at FRC. But in case of certain types of disease, the dependence on volume or flow or the breathing cycle can be important. As for instance, in this example, this is a model of a flow-dependent resistance, when you can see that if we measure cycle by cycle the impedance, we have a value like this, a flow dependence 1, and that if we measure this data along all the breathing cycle, we have this mean value. Of course, there is no problem because we get the mean value. But if we, in that case, we average along all the breathing cycle, we can lose important physiopathological information. Let's move now about some comments about interpretation. It is well known, although sometimes I think that it's not sufficiently appreciated, but this, of course, can be my obsession. Well known that in the conventional setting of oscillometry, not all the flow that is measured at the pneumotachograph is going into the respiratory system. Part of this flow is shunted at the compliant extrathoracic airways, even in the case that the cheeks are supported as usual. So this was very well studied. And you can see here an example, the simulation example, which is realistic, when you can see in black the typical impedance of a patient which is normal with just increase in a little bit increase in central resistance. Instead of 2, 3 is 6, but the reactance is quite normal. This in black is the actual impedance. In red is the result that we obtain when the role of the extrathoracic upper airways is considered. And we can see that apparently this patient that in principle has no frequency dependence of resistance appears as having a frequency dependence and also a shift in the reactance and an increase in the resonance frequency, which could be interpreted as if it was a patient. So the effect of the extrathoracic upper airways is to reduce the sensitivity of the technique to detect impedance changes within a patient and to potentially induce misinterpretations of the frequency dependence of resistance and reactance. So this is a question that should be taken into account when trying to interpret the results obtained with the conventional setting. About interpretation, it has been, especially in the past, but also implicitly currently, to interpret the data in terms of models. So a model of serial high homogeneity, for instance, increasing in the peripheral resistance of the airways, or parallel inhomogeneity, or even a modeling the viscoelasticity of the tissues that we know that it exists. The problem, let's say, it's not a problem, but the fact is that these three models are absolutely equivalent in terms of the equation, the driving equation they are driven by the same equation, where these parameters A, B, C, D are a combination of the resistances and elastances. And also, it happens, of course, in the frequency domain. So the resistance and the reactance has exactly the same functional form in the three models. For instance, we have that these three models with the convenient values of the parameters, all these three models, which are absolutely different in theory from the concept, present exactly the same impedance. So this impedance is either the impedance of this model, or this model, or this model. So by fitting the impedance data of a patient, it is impossible to distinguish whether the observed resistance and reactance are caused by an increase in peripheral resistance or parallel homogeneity or alteration of tissue viscoelasticity. When using models, it's also important to take into account the concept of parameter sensitivity, which gives us an idea about how sensitive or how variable is a parameter depending on the noise from the original signal. Here we have an example of a simulation of a normal patient, a healthy patient, and this is a theoretical value in lines, and this could be an example of a measurement with measurement noise. Okay, so the sensitivity of the parameters in this linear simple model, by definition, is here. I will not go into detail, but the sensitivity of the resistance is constant, does not depend on frequency. The sensitivity of the inertance increase with frequency, and on the contrary, the sensitivity of elastance decreases inversionally with frequency. What does it mean? This means that if we take the fitting, if we fit the data from the lowest frequency range, we, in a simulation population, we can obtain this coefficient of variations of resistance, inertance, and elastance. But see, if from the same values of original impedance, we carried out the fitting from the highest frequency values, we found, of course, as expected, because the sensitivity of resistance does not depend on frequency, a slight greater variability from the lowest frequencies, but particularly in that case, you can see that the coefficient of variation from this data is only 10%, and from this data are more than 100%, and the reason is this one. So it is important to, I would not to say to avoid models, but when using models, to be careful about the sensitivity of the parameters. And that's why I think that's very important, what is usually done currently, that regardless of fitting models, it is very important to keep the raw resistance and reactant data, resistance data, because these are data and are not depending on the reliability of models. An alternative to the interpretation with models that I showed before is another one. Instead of inverse modeling, the possibility is the direct modeling. It consists in just taking a geometric model of the respiratory system, the different generations, and then for each single generation to assign values of the resistance, the inertance, the compliance of the wall of this generation, and also the compliance of the gas inside this generation, and then to put the different generations one after the other, and at the end to put a tissue compartment, which can be a viscoelastic tissue compartment, so that this can generate the whole impedance of the lung, and then one can play, let's say, modifying at will the values of resistance, compliance, inertance of each generation, and also of the terminal tissue compartment. And such direct modeling is to understand, helps us to understand how resistance and reactance or impedance will change depending on how we model the different values of the generations. So this direct modeling is not to derive parameters. There are hundreds, if you want, of parameters here, so it's impossible to derive all the parameters from the measurements, but it may help us to understand in more detail what is happening with the data. Finally, regarding interpretation, there is another point of view that I think that should be taken into account, is the within breath variation of impedance. As I mentioned it, and everybody knows, this is of minor importance in healthy subjects, but in some patients, this can be very, very, very important. And you have here an example that could correspond to a COPD patient, for instance, in supine or in a severe disease, where he or she exhibits almost no change in resistance along the breathing cycle, but huge difference between the inspiratory and the expiratory values of reactants. You can see here that during inspiration, the value of reactants is -2, more or less normal, but by contrast, during the expiration is -6, so it's 3 times greater or lower if you want. It has been shown by comparing these impedance data with the use of esophageal balloons to detect expiratory flow limitation, that this kind of change of impedance, in particular of the reactants, can be interpreted in terms of expiratory flow limitation in a way that during the inspiration there is no flow limitation, so we have a situation where in a very simplified way, all the oscillation arrives to the end of the system. But in the case that there is choke point or flow limitation, there is what we could be or is known as the expiratory flow limitation, the baby low. So the value change. So it has been shown with comparison with esophageal balloon measurements that in case that the change between inspiratory and expiratory reactants is greater than a certain threshold, there is expiratory flow limitation. So what it means is that it is important, in my opinion, especially in patients, to consider and to analyze to what extent there are clear differences between inspiration and expirations, because if not, we can lose important physiopathological information. So just to finish with this very, very, very fast perspective of the theoretical basis of oscillometry, I think that the theoretical basis of oscillometry provide clues to optimize the measurement and interpretation of respiratory impedance. The equipment, which means the oscillation generator, the transducers, and the data processing, should be adapted to each oscillometry application. So for children, for adults, for sleep, for mechanical ventilation, whatever. Also, that different technical implementations, which means oscillometry devices, different brands and models of devices, may cause results variance. Because depending on whether all the frequency responses are corrected, or whether the different details of construction, it's normal, if you want, or it's reasonable that there are some differences. So this realizes the need we have to characterize the different equipment and also to carry out quality control. Another thing that I understand that it's clear from the theory is that any mechanistic analysis of oscillometry should be made carefully to avoid misinterpretations, taking into account the upper airway shunt, the disease complexity, the difficulties of modeling, and in particular, for instance, it should be careful to interpret some changes in resistance and reactance exclusively as peripheral resistance of peripheral airways. And final comment is that reporting the within breath time course of resistance and reactance seems to be most useful, since it can allow further reanalysis. So even if we only take care now in a given study, on a given measurement of the mean impedance along the breathing cycle, which is the most obvious and simple, I think it's important to store the data, the raw data, because this can allow in the future to reanalyze the data in case that we want to look at the differences between inspiration and expiration. And that's all. Thank you very much for your attention, and I hope that this presentation has been interesting for you. Thank you.
Thank you, Ramon.
All basics.
Questions, I guess we'll start within the room. I have a comment. I very much enjoyed it. Let's see if there's.
I wrote my own stop sharing the screen.
Okay, can you stop sharing your screen?
I'll make a comment.
Yeah, I stopped sharing. Let me see.
David will make a comment and then I'll try to go to the online people.
Yes.
Ramon, David Kaminsky here. Thank you. I also really enjoyed your talk. The slide you showed about the effects of upper airway shunt is very important. And I think it's highly underappreciated how that might contribute to frequency dependence of resistance. And as you said, it's commonly misinterpreted as solely being evidence of small airways disease. And I still think it's more fair to say it may be indicative of small airways disease, but it's also indicative of ventilation heterogeneity, and it can occur due to shunting effects as well. So we don't want to be overinterpreting that one parameter.
Yeah.
Right.
I agree.
A quick comment on that. I looked at the literature in terms of the frequency dependence of resistance using the head generator versus not, which eliminates the upper airway shunt in subjects. And one paper did show that with and without the head generator, frequency dependence disappeared, right? But all the others, and they expanded a wide range of impedance, did not. It was largely a shift. So it's difficult for me to know which papers were actually right out of those 5 out of the 4. So
Yeah.
I think it needs physiological measurement
Well,
in addition to modeling to know for sure.
I was
yeah,
gonna say, I've
as-
generated.
sorry.
Ramon? Yeah, go ahead, Ramon.
Yeah, no, just a comment. You know that the development of the concept of the role of the extrathoracic upper airway was developed more than 30 years ago, mainly by René Pelin, and they carried out different studies. I think that showed the differences. Many years ago, I carried out some studies comparing conventional impedance with the head generator, and I really observed the same kind of differences. But I think that, of course, these are old studies. So I think that to the extent that people think that this could be important, perhaps this is something that can be retaken, and if there are doubts, to be sure about that. So I would suggest that perhaps re-elaborating a little bit this after more than 30 years could be interesting to clarify the situation.
Thank you, Ramon. Very sorry to delay. Zoli, can you unmute?
I'm unmuted. Ramon, thank you very much for the wonderful presentation. So we are from the same club, and I'm not sure that you would enjoy my talk as much as I've enjoyed yours, but congratulations. Just a short comment. I was most pleased when you concluded at the within breath or more precisely intra-breath changes, their importance. Just one comment on your notion that these changes are not, these are minor in healthies. It is not exactly true. So, but what is definitely different from the healthies and the obstructed subjects, that the nonlinearity, the flow dependence, is dominating in the upper airways in the healthies. So percentage changes are huge, even if don't express themselves in the reactive part of the impedance. The other thing is classical, more than 20 years old paper from Delacroix and colleagues, the physiological validation of the tidal EFL technique based on the non-invasive oscillometry. The changes in resistance in that example and in many similar measurements in COPD are relatively minor, whereas there are huge swings in reactance. So why resistance does not change in the meantime? And the choke point effect is what you pointed out, is the key. The periphery can't supply sufficient flow to the upper airways, which are fundamentally non-linear, and that's why resistance is high, but not fluctuating very much within the respiratory cycle. So this is just a comment. Congratulations again. Thank you.
Yeah, thank you. Just a comment. Of course, there are also changes along the cycle in healthy people, but of course, is a minor input. Minor. There are minor as compared with the ones in several kind of patients. So. There are changes, but it's less important quantitatively, I mean.
Okay, we have two more hands up online. Do we have time for two?
Yep.
We have time. So Sam first, and then Felix. Okay.
Yeah, thanks very much. Thank you, Ramon, for a wonderful talk. And thanks, Ron, for organizing this. Yeah, Ramon, you mentioned the effects of heterogeneity, area compliance in the frequency dependence. Can you please comment on using admittance versus impedance, and does that help in any way, or is it just a more confusing?
So could you repeat, please, the question?
Can you please comment on the use of admittance
well,
instead of impedance?
Well, I presented this topic 2 or 3 years ago here in this meeting in Montreal. The only advantage of using admittance, the only one, I think it's not minor, but the only one, is that if you quantify any change within a patient, so between inspiration and expiration, or pre-post bronchoconstriction or bronchodilation, if you compute the difference of admittance, the data are free from this extrathoracic upper airway shunt. Okay? I think that this is not minor, but then there is a question also, a warning question. So the absolute difference of admittance is free of the artifact. But if you normalize by the value of the admittance, then you again take the bias. Okay?
Can you define admittance for the medical students?
Pardon me?
Can you define admittance for the students?
Admittance is 1 over the resistance, isn't it?
It's one over the, it's the.
1 over the impedance, 1 over the entire thing.
But I need clarification. I mean, if you measure input impedance and then just invert it, that's going to be affected by the shunt as well. I think maybe what he means is you're applying oscillations and pressure around the test wall and measuring the flow here. That is independent of it.
Yeah,
that would be true, yeah. So admittance being 1 over the impedance can't be, it can diminish it because the errors change, the effect of the errors change.
Oh, I guess so.
But they don't completely vanish.
Yeah. But when you're blowing in here, you can get this.
Yeah.
Pounding here, it's come straight.
Yeah, so that's a very rare technique where we're doing forced oscillation by oscillating the chest.
Yeah, but I don't know words all the time with chest physics.
Okay, with that discussion, we have one more hand up. Go ahead.
Yeah, just a very short question based on your very nice talk. Do you think it's ever possible that we harmonize any kind of forced oscillometry device to get normal values which we can use universal based on absolute values, or let's say Z-scores, or will it never be possible based on what you just showed?
Well, this is the eternal question. It would be great to arrive to an agreement about the technical definition of impedance. In a similar way, of many years ago, it was possible with the devices measuring forced spirometry, that it was the standard spirometers, the standard spirometries and so on. It could be possible, but technically, an oscillometer has much more details, technical details, than a forced spirometry. So it's not so easy, but it could be perfectly easy, in theory, to arrive to an agreement about definition of a standard analog system for calibration. There is no ideal one, so we could get an agreement, and also we could agree on the different ways of processing the data and the different characteristics of the sensor and so on. This could be possible. But my experience on almost 40 years in the field of oscillometry has shown me that the different companies commercializing oscillometers has legitimately their interests, and sometimes they try to sell more than a good oscillometer device. They want to send their oscillometer device. So presenting each one a different report, each one giving different weight to different parameters. So unless there is some authority, I mean the ATS or the ERS, then executively decides or force to sit down different companies, pharma companies, oscillometry companies, to achieve an agreement. Unless this happens, this will be impossible, because every company is trying to defend legitimately their way of computing. So this is my viewpoint. So my viewpoint is that only if there is a big authority like a society that promotes and compulsory forces people, all kind of people, clinicians, pharma companies, and oscillometry device companies, to reach an agreement, I think it will be impossible.
Thank
What
you.
a really good idea. I like that.
You're speaking against yourselves here.
Yeah,
Just-
I think I'll take the executive moderator power and conclude for coffee, but I will make one point on that one, and that is giving the ATS ERS executive power and then agreeing upon an analog model that should mimic some of the effects of what a patient actually does when they're breathing is an extremely good goal. And I think that obviates some of the problems that the companies are trying to do in terms of changing their analysis or trying to calibrate differently and so on, because they have to get within a certain percentage of accuracy the results that experts agree that the analog model is actually producing. After that, it's the screen, it's how they're trying to market and so on. I'll conclude with my personal comment on that. Can we save that for coffee there? Charlie?
Well, I think.
Charlie's not going to save it.
No. I think the lessons that we learned from the standardization and simulations, spirometry, need to be revisited, because there's some major pitfalls in that. It's a great idea. I don't disagree with you at all. But I think it has some real serious pitfalls if not carefully managed.
All right. Carefully managed power. Very good.
10-minute coffee?
10-minute coffee is what Ron is suggesting. So we'll be back in 10.
Okay.
11:05 by our time. Thank you very much, Ramon.
Okay.
Thank you. Enjoy.
It's not as good as your coffee, Ramon.
10 minutes, go time. Okay.
All right, we'll go ahead and get started. Zoli, I'm just going to introduce you. First of all, I just want to say thank you for asking me to moderate this final session. Good to see everyone here just before lunch and the close of our meeting. And we're very pleased, of course, to introduce Zoltán Hantos from Hungary, who's going to talk to us about modeling mean and intra-breath impedance spectra. So Zoli, when you're ready, you're all set to go. That looks right. Perfect.
Oh, is it? Thank you very much. Thanks, Harry, for the help. I need help every time, apparently. First of all, let me thank Ron for organizing this meeting the 9th time, and probably not the last time, and allow me to participate with my talk. It's a sort of archaeological exercise in the modeling, or which I think is from the basic question: if we have abundance of impedance data versus frequency, in both sense. Huge databases, many measurements and from many centers around the world. This is one kind of abundance, and the abundance is the frequency points in which we estimate impedance. And the question is, do we utilize all the information hidden in these data? Currently not. From the resistance values, we only use points, the lowest frequency, and one medium frequency, 19 or 20 Hertz, and of course, their difference. The situation is a little bit better with the reactance data, where in addition to the lowest frequency reactance and the resonance frequency, which is basically uses 2 points, one negative and the positive point. We don't use many of these data points. AX is the leader in many ways in the interpretation of impedance curves nowadays. It's in a better position because it combines several data points, not all, of course. But why is it that famous and prioritized measure? The basic issue is the lowest frequency reactance may have huge scatters, and involvement of higher frequency and more stable reactance data would give probably a more robust estimate of the reactance behavior. Second thing, it has a nice unit because it has the unit of the elasticity and simply pressure over volume. But at the same time, several issues arise, like what happens if don't reach the resonance frequency in the measurement range, or do we truncate these values, or so there are lots of questions about that. So what if we go back to the past and try to utilize all the measured impedance data by using models? These slides I use the electrical circuit equivalent to the mechanical one. Probably it's very familiar to all the audience. It is, or it simply corresponds to the basic equation of motion of the simplest equation of motion of the respiratory system, consisting of a resistive, an inertive, and a capacitive setting. As Ramon pointed out, there is a very primary bias introduced by the upper airway wall shunt, which can be handled by a simple capacitive upper airway wall compliance in front of this RLC. Classical model, which is uniquely attributable to Du Bois, which is central airway compartment consisting of a resistor and an inertance, and a peripheral part, which is tissue compartment, and there is a shunt compliance, which is the gas compliance of the alveolar gas, shunting the rest, that is the tissue resistance. This is one model which can be addressed. The next model is quite complicated. It can't be ascribed to one single person, although it starts with probably the Otis paper, which had 2 RC compartments in parallel. The next step, Jerry Mead made one branch, simple compliant, which represents a bronchial wall shunt compliance, shunting the rest of the periphery. This model was complemented by an in-series resistor and inertance later, which was unable to account for the rise of resistance in many cases at higher frequencies. So Jackson and Lucian finalized this model by putting a central parallel wave wall compliance. And there is another model which we address now here. This is the fractional order model, which was published in this form by UNESCO and de Keyser. It is a very nice generalization of the constant phase tissue model by adding not only a resistive part, but a complex inertive part, which has a real part and an imaginary part. So it's not simply an inertance, it has a linearly frequency-dependent resistor, which can eventually account for the rise in resistance at higher frequencies. So it goes back to the old tissue rheology papers, which are included in this tissue impedance of constant phase nature. I apologize for these extensive equations, but my point is that all the referred persons here had an MD degree and they were not afraid of writing down complex impedance equations. So I won't address all the possible models because some of them are conceptually wrong, even if they have a good fit to the measured data. So apart from this fractional order model, which was not involved or addressed by Jason's book, I refer this source for everyday use. The impedance data which we try to model were obtained in a study. It's from the Rhododendron's pulmonology clinic, and they were all measured with Tremoflow C100 devices, which has quite a few frequency points to be used. And recently we analyzed the intrabed behavior of this impedance at the participating frequencies, not all shown here because it would have made the graphs very busy, but just the principal components. And from these measurements, we addressed healthy IRD, asthma, and COPD subjects measurements in terms of the mean impedance value, resistance and reactance, plus and expiratory and inspiratory, minimum X and maximum X, and maximum R and minimum R. So the whole range of which these spectra span is the intrabed endpoints of impedance. So the maximum resistance and minimum reactance, these are healthy persons, but probably the relative changes are almost as large as in the obstructed patients, but we will restrict ourselves for the expiratory and inspiratory points where the respiratory flow is zero, and probably the upper airway nonlinearities are of the least importance. And of course, for comparison, we take the mean impedance from the whole respiratory cycles. So these are the non-obstructive group data, individual data. All groups had equal numbers. Probably the ILDs were the less, but we adjusted that number to the other groups. So what we see here is relatively frequency independent, slightly rising resistance values at expiration, lower values but still rising at end inspiration. Not much change in reactance, apart from steeper rise in reactance with frequency. Same is true basically to the ILD subjects who have lower reactance values, and the changes between end expiration and inspiration is not very remarkable from the graphs. But by contrast, in the asthma and COPD groups, at end expiration, we have marked negative frequency dependence with a later small rise in resistance, which almost diminishes end inspiration. Whereas the differences in inter-individual differences in reactance are minimized almost and inspiration. So there is a sort of normalization, what we can see in the asthma and the COPD group between end expiration and inspiration. So these individual data were fitted with some review model fitting algorithms consisting of a global search and the local optimization process. And this is model one, which is a simple resistance inertance compliance model showing huge discrepancy with the frequency dependence because it just takes one average resistance value. And there are some systematic differences from the measured data and the fitted model. The next model, I skipped the next the model 2, which is just RLC with a shunt compliance, because it did not reveal much changes. So this is model 3, the fractional order model, which follows this negative frequency dependence here and fits nicely to the reactance data. Model 4, which is the Boyce model, we can call it that way, misses the later rise in resistance, but not in all cases, whereas the reactance values are extremely nicely fitted. And this is model 5, which is the Bucky's Mead Ice Jackson-Luchen model, which is able to follow both the later rise in resistance, the early fall in resistance, and perfect fitting to the reactance data. So if we look at the performance of the models in terms of the fitting error, which is an absolute impedance difference, we can see that the healthy subjects and in the ILDs, inclusion of a shunt compliance in front of the ILC model improves fitting quality. This model 3, the fractional order model, shows a further improvement in the fitting error, the fitting quality, in other terms, in end expiration and inspiration. Further improvement can be seen with the Boyce model, And this model 5 has basically a more impairment and inspiration, but this is not true for the eye of the subject. By contrast, the obstructed subject, there's not much difference between the first models. Big improvement in with the fractional order model, further improvements with models 4 and model 3 and 4 and 5. Same for in inspiration. But note that differences between the fitting errors are far less between models than the inspiration, both in the asthma and COPD subjects, showing that these subjects approach the ideal RLC model, RIC model behavior and inspiration, which is absolutely not true for the mean values and particularly the end expiratory values. If you look at the resonance frequency, it's not very, very important because the models basically approach the resonance environment behavior of reactants, and there's not much difference between expiration and inspiration. But in the obstructive groups, there's a huge drop in resonance frequency in asthma and the COPD compared to the end expiratory state. Leave the R values here because there's just one resistance in model 1 and model 2, just for comparison. And we can see the central resistance that is in front of the shunt compliance of the bronchi in model 5, or the shunt compliance of the alveolar gas in model 4. There are smaller values than the average value taken by the RIC model, but the fractional order model has very indeterminate central resistance value and huge scatter in the data, both in the healthy and the ILD subjects. So even worse in the asthma and COPD subjects, where you have quite nice agreement with the last two models at end expiration and inspiration, and I don't know. So from this point on, with the notion that the tissue hysterosensitivity data, which are basically the tissue damping over tissue elastance, whose values are found between 0.1 and 0.3 in general. Lung parenchyma has a lower hysterosensitivity than the chest wall tissues, etc., but it's basically under 0.3. But in these fitting, whatever we tried with the different fitting algorithms, the hysterosensitivity remained between 0.6 and 0.9, which is totally impossible to characterize tissue rheology. So from this point on, we dropped these model fittings because we conclude that these tissue rheology, which is incorporated in the fractional order model tissue part, is not appropriate for medium frequencies. It was constructed by frequencies from the breathing rate and up to a couple of hertz frequencies. So now, peripheral resistance without the fractional order model, we can see that in healthies, these are very low values, sometimes not very determined, less than the average value, of course, because we have now resistances. IRD, these are more variable, but still probably the smaller part compared to the central. But in the obstructive groups, we see that peripheral resistance is estimated huge, even in the average values, whereas in and inspiration, huge peripheral resistance estimates drop down to much smaller values. So the last thing to look at is probably the peripheral compliance, which is higher than at end expiration compared to end inspiration in the healthy and IRD subjects, probably resulting from the fact that end inspiration, even if the lung tissues are not stretched during shadow breathing, but the chestal compartment is more stiff because of the activity of the inspiratory muscles, brings down the compliance to a lower level. It starts from 0.4-ish level, 0.04, and goes down to 0.02. Whole thing is lower in IRD, but in asthma and COPD, we have very, very low values and expiration, some improvement and inspiration. So it is just just contrary to what we found in the non-obstructed subject. But the very, very low values of compliance at end expiration compared to the non-obstructed subjects raises some questions. So we have some conclusions from this preliminary study. We can demonstrate that the end expiratory and inspiratory impedance spectra are very different in all subject groups. Simple tidal inspiration tries to homogenize the different groups and inspiration. So the obstructed groups behave much closer to the normal and inspiration. We can probably conclude that these models, model 3 and model 4 and model 5, and maybe the simplest one, which doesn't separate the central and peripheral resistance, are probably good representative of all data which we measured, but the two models which partition resistance into central and peripheral parts perform similarly, and partitioning seems reasonable. However, the CRS values, which are lower in the obstructed subjects, despite the fact that the parenchyma is less stiff in COPD, but at oscillation frequencies, high frequencies, it's probably the dynamic compliance fall coming from the fact that the peripheral units are very, very heterogeneous. And these models don't account for this peripheral heterogeneity. They are all lumped and have shunt compliance in front of a shunted peripheral impedance. And this is definitely a weakness of this modeling approach. As I state, these very elegant fractional order models are basically not relevant for impedance data measured at medium frequencies, 4-5 Hz and above. And there's one very serious issue that probably a single compliance for representing the upper airway shunt is not a proper representation because it's a very complex viscoelastic tissue impedance, and probably to account for that would be a way to look at the spectra and the modeling interpretation differently. So thank you very much for your sympathy for these obsolete modeling efforts and for your attention.
Thank you very much, Zoli. Are there any questions? Jason has a comment or a question.
Yeah, Hi, it's Jason here. A beautiful demonstration of the fact that you cannot make any kind of physiological interpretation of impedance without a model. Just what I've been saying, but you just demonstrated it well. And there's no one single model that fits, so it's a bit of a complex issue. So there's one comment I want to make though. In the obstructive patients, you found that end expiration compliance was reduced compared to end inspiration, correct?
Yes.
And I would interpret that as being reflective of de-recruitment of the lung. Because if you have a soggy lung where you have inflammation, like in asthma, allergic asthma, you have, the propensity to de-recruit the lung when you go down to the end of expiration, and so the compliance is going down. That would be my guess as to how you'd interpret that.
A very good point, Jason. So if you look at the whole course of resistance and reactance during these intra-breath measurements, we see this huge dynamics, and you are right, it can be a sort of a periodic recruitment and de-recruitment behind, and that explains. So that is probably the one positive remark on this obituary on obsolete modeling efforts, which I try to perform now.
There's an online comment, David.
Okay, online.
There's, I think, Sue Bakash Day. If you're there, you've written a comment, you can turn on your camera and address the audience.
Your comment, Sue?
And otherwise, I'll read it out. It says, "Sir, are these non-linear models used to fit impedance data behavioral or phenomenological? As iOS is based on the assumption of linear lung model, a phenomenological model for impedance data should be more explainable for understanding intra-breath physiology." It would probably be best to explain yourself because I'm not familiar with the phenomenological models unless Jason, you
Oh, I'll let Zoli have it.
okay.
Did you hear the comment, Zoli?
Yeah, I can read the comment. Yeah, that's a good point. So it's not only iOS which considers impedance as time invariant and linear. All the spectral estimations have these basic assumptions. So the intra-breath multi-tracking types, when we look at impedance spectra from time point to time point, pick up short time intervals within which probably the changes are negligible. It's tedious, but if we collect from the same time segment from every breath, a sufficient number of data, we can follow that change. And nonlinear models in the time domain have been shown some very, very important volume dependence of resistance, volume dependence of elastance, flow dependence of both, and sometimes flow and volume dependence of inertance, which is probably less important. So these are not phenomenological, but mechanistical models, but they are lumped. That's one issue, the time domain approach.
There's also one
That's
point. Yeah, I'm not sure if I understood the comment correctly, but all of the models that Zoli showed are linear. I mean, they may be complex and have lots of bits, but they're still linear. There's no nonlinear.
Yes. All the models which we addressed, they are linear models, but we employed these models to short segments of time within which the impedance did not vary. And then step to the next time segment.
Thank you, Zoe. I'm glad you could answer that question. I'll just finish this talk by saying something that Jason taught me many, many years ago, which is all models are wrong. Some are useful.
I'd love to be able to claim that as my own, but I can't. It comes from George Fox from years ago.
Correct. You were telling us about someone else. That's right. Thank you so much, Zoe. We appreciate it. Great. And our next speaker is Dr. Rory Chen from University of Dundee, UK. And let's see if we can get your slides up here. Perfect. And if you want to turn on your camera, Rory, that would be great too, if you don't mind. And we need you to go into presentation mode if possible on your end.
Hi, David. Can you hear me?
Yes.
Yeah. I think I have turned my camera on. I'm not sure if you can see me.
We see you and we hear you, but you're in the
So David, the three lines.
Oh, that's for me to do.
The middle one.
Okay.
Yeah.
Got it.
No, that's
No, it's on his end, right?
Yeah, he has to do
That's
it
what I
on his end, but that's where.
Carrying the wrong speed.
Click.
Rory, in the middle on the top, there's this display settings tab. And if you click on that, I don't know if you see that on your end.
Oh, yeah. Got it.
Yep. And then come down and swap.
Swap. Yeah.
There we go.
Perfect.
Okay, Rory,
Perfect.
take it away.
Great. Thanks, David. Thanks very much to Ron as well for organizing and inviting me to this very amazing seminar. Surprisingly, it's the first time last year that I realized something like this existed on an annual basis. So I'm very glad to be part of this year's one. I've been asked to talk about the role of oscillometry in asthma. So my name's Rory. I'm mainly a clinician, first of all, but I also do some clinical research in airways disease. So hearing all the talks on mathematical modeling and the physics behind oscillometry is very interesting, even though I don't necessarily understand all of it. So looking at oscillometry as a whole, we know asthma is a disease of the small airways, which comprise generations 8 to 23 of the bronchial tree. And the reason why spirometry is less favorable to use is because of many papers, but one of them was published by James Hansen in 2006 in Chest, showing that FEF 25 to 75 or mid-expiratory flow is a very volume dependent, but also a very age dependent variable, and changes according to a person's age, and essentially is not as consistent as other variables. Marcello Catini from Italy, who's my good collaborator, looked at his data set of 300 patients with entirely normal FEV1, FEF 25 to 75, and also FEV1 to FVC ratio, and then further split this group into those with small airways disease using oscillometry or those without. And you can see here that patients with SAD have 4 times the number of exacerbations and also night awakenings, 10 times the number of ER visits, but also greater evidence of type 2 inflammation, as denoted by FeNO and also blood eosinophil counts. The Atlantis cohort was also the largest prospective trial to date, published in Lancet Respiratory Medicine a few years ago, showing the increased prevalence of small airways disease with advancing GINA stages of severity of asthma. And this was across the board, regardless whether you use spirometry, oscillometry, multiple breath nitrogen washout, or even body plethysmography. And if you looked at all the modalities as a whole, about 90% of patients with asthma have SAD. We published a paper in ERJ a few years ago looking at combining spirometry with oscillometry, and what we found was that if you have impaired oscillometry with impaired spirometry, then you have significantly worse symptom control, but also greater exacerbation frequency, which in itself is linked to mortality, longitudinal lung function decline, and also repeated uses of corticosteroid courses, which in itself are related to a lot of side effects and mortality in itself. We also published this letter in ERJ showing that across approximately a year in patients with severe asthma who were taking high doses of inhaled corticosteroids with poorly controlled asthma with a high ACQ and also greater exacerbation frequency amounting to about 4 per year, that various different parameters could be calculated, including this concept of biological variability that Sandeep mentioned earlier, where the minimum value that must be exceeded for a clinically relevant treatment effect was calculated. And what we roughly estimated this to be for R5-20 was 0.04 for our cohort of severe asthmatics and 0.4 for AX. And what the Alliance cohort then subsequently did, in a couple of years later in the same journal, was that they published similar values but across the severity of asthma spectrum, so mild, moderate to severe, and their values were pretty similar, but they're shown in the brackets there. Another reason why I very much enjoy using oscillometry is because it closely relates to a surrogate of area remodeling that we use, obviously called bronchial wall thickening on high-resolution CT imaging. And this is a study where our radiologists painstakingly and manually measured the bronchial wall thickness across about 100 patients with persistent asthma. And we calculated adjusted odds ratios, which are presented here with 95% confidence intervals across 4 different bronchopulmonary segments in the lungs. And you can see that R5-20 as a ratio of R5, AX, and also frequent exacerbations significantly associated with bronchial wall thickening, but FEV1 did not. Oscillometry also shows usefulness in distinguishing between different effects of biologics, and these were 2 phase 4 single arm trials that we performed in Scotland, looking at the effect of benralizumab and dupilumab on the primary outcome of mannitol challenge, and this was a separate primary outcome. But from these 2 trials, because they had very similar study designs and they essentially looked at the 12-week period of treatment, we selected patients from each arm and case matched them using baseline SAD parameters and essentially looked at the effect of benralizumab, which is anti-IL-5 receptor alpha, versus dupilumab, which is anti-IL-4 receptor alpha, and looked at the responses individually in the patients. The numbers were small, but you can see from the graphs that the responses, both in terms of R5-20 and AX pre versus post therapy, were significantly more homogeneous with dupilumab therapy, with the between treatment differences being significant. So it does appear that if you target interleukin 13 and 4, which we know are responsible for bronchoconstriction, but also mucus hypersecretion, and both of these pathological processes do influence lung function. So that is probably the mechanism by which dupilumab is superior to benra when it comes to small airways disease. We also looked at a couple of more novel aspects of oscillometry, which admittedly do require more research to confirm and validate, but I thought I'd show it here as well, and this is probably the best forum to initiate some discussion. But we looked at something that is seldom looked at in asthma, which is mediastinal lymph node size on high-resolution CT imaging. And mediastinal lymph node size typically has been used in sarcoidosis, of course, and lung cancer, but we looked at the various EBUS stations, so the endobronchial ultrasound stations 2, 4, 5, and 7. And we published this paper in blue where we separated the group into 3 different tertiles. And essentially the patients with the larger mediastinal lymph nodes actually had worse oscillometry, both as R5-20 and its ratio, but also as AX. FEV1, there was some signal, but this did not quite achieve statistical significance. On the right-hand side, we looked at a paper where we essentially looked at our patients in Scotland, essentially in women who had HRCTs with persistent asthma, and we took the paraspinal muscle density value, which is measured in Hounsfield units at T12, especially the erector spinae muscles, And we showed that patients with higher muscle density and therefore lower adiposity actually had better lung function as denoted by oscillometry, but not with FEV1, again showing that oscillometry is perhaps a more sensitive measurement of airways caliber and stiffness compared to spirometry. And then finally, I just wanted to show this study as well that we are currently trying to publish. And this is a study that I'm currently working with Ron and also with Sandeep, as well as various other collaborators around the world, where we took a cohort of patients in Dundee, first of all, in the UK, amounting to about 250 patients. And these patients all had moderate to severe disease corresponding to GINA 3 to 5 stage. And we also approached Marcello Catini with his Italian cohort amounting to about 360 patients. And we created the Oscillometry Asthma Registry, which formed the retrospective discovery cohort in this study. And at the time, it had about 617 patients. And now we're almost approaching 1,000 patients, and we're still getting some solicitations from various different researchers around the world to hopefully join this. So we are hoping to formalize this properly and open it up to everyone to join, for anyone who's interested. For the prospective validation cohort, we approached Salman Siddiqui, who very kindly offered his 400 moderate to severe patients from the Atlantis group. And of course, Atlantis was a prospective validation cohort. To give an idea of what the study was about, we looked at 4 main parameters, being inflammation, which encompassed blood eosinophil count above 300 cells per microliter, FeNO above 25 parts per billion, and also physiological parameters such as R5-20 greater than 0.1 kilopascals per liter per second. And I know from earlier cutoffs and lower limit of normal is quite a controversial topic. FEV1 was also the 4th parameter where we used less than 80%. And in the OR cohort, 27% of patients had basically the triple high phenotype, where they had high eosinophils, high FeNO, and abnormal R5-20. And if you only had high eosinophils without FeNO or impaired oscillometry, then you were sitting in the 14.9% of patients. The money slide is essentially shown here, and this abstract was accepted as an oral presentation at ATS, but unfortunately I didn't get to go for various reasons. But the adjusted odds ratios are presented here, associating basically if a patient has a FeNO of 25 parts per billion or greater, then their adjusted odds ratio for 1 or more exacerbations in the previous year was 2.6. If you looked at patients with an FEV1 less than 80% plus a FeNO of greater than 25 parts per billion, then that risk would be tripled to 7.5, and then it would be further doubled if you included R5-20 as well. And I think this concept isn't exactly surprising, because if you look at more and more severe patients with various different things wrong with them, then of course you're going to get that increased risk. And what was interesting was when we continued to look at the quadruple biomarker, the numbers got smaller and smaller, but when we added blood eosinophils, then the risk actually jumped even more. And I guess why should we stop there? Because we know previous exacerbations and also symptom control are also very close contributors to exacerbation risk. So potentially something like this could be used in clinical practice eventually to predict the risk of patients and prevent and treat patients before they actually have multiple exacerbations with the associated mortality. And what was interesting about this study was that we also looked at the Atlantis cohort and essentially validated our idea using their data prospectively as well. So not only did our data look at previous exacerbations, their data looked at future ones to show that this model actually works for both previous and future exacerbations. I guess one of the frustrating things that I encounter in clinical practice, and I'm sure many clinicians are the same, is that we measure FeNO and blood eosinophils to fully characterize inflammation in asthma. using fully in inverted commas, but for physiological assessment, we only really rely on the FEV1, or if someone's feeling adventurous, we use the FEF 25 to 75 as well. But really, we should be measuring the small airways and the large and medium airways, using oscillometry as well. I guess to finish off, this is a flowchart that we recently published in CHEST, proposing that we can potentially use oscillometry in clinical practice. And this is a small project that I did with Errol and some other colleagues as well, who I don't think have been able to attend this meeting today. So I think in summary, oscillometry is really useful in asthma. We use it in clinical practice to distinguish whether patients might be, responsive to extra fine inhaled particles, which we've not really discussed in this lecture, but also biologics. We've got minimal clinical important difference and biological variability values now, which will aid in clinical diagnosis and management. But also novel avenues for oscillometry use are also very, very interesting. And I look forward to, next year and the years in the future where more information will come out. So thank you again for listening, and be very glad to take any questions.
Thank you very much, Rory. I have to say, you're one of the most productive clinician scientists that I can imagine.
Thanks.
With all that work and publications, that's really very impressive. Are there any questions from the audience for Rory? Yes, Charlie.
Rory, wonderful presentation. Your data that you're showing here in this slide supports something I've felt for a long time, and that is that exhaled nitric oxide isn't terribly helpful, or it doesn't really add a lot. Would you agree with that based on your data?
Yeah, I think, I have certainly heard some people suggest that pheno isn't very, very useful. And I think looking at the data, just on the screen here, when you look at blood eosinophils and pheno, for the OR data and also for Atlantis, so these are not the ones that I've highlighted, but PBE plus pheno, the adjusted odds ratios for both groups is only about 2. And it's only when you add in the physiological parameters such as FEV1 and also R5-20, that's where the real risk jumps. And when you look at the Oracle data, which was recently published in Lancet Respiratory Medicine, it does show that if, that pheno and blood eosinophils are associated with an increased risk, but their analysis used log 10 pheno and log 10 eosinophils, which suggests that, tenfold increases are associated with exacerbations, which perhaps isn't as clinically relevant as the physiological parameters that we see, because, to get a tenfold increase, you'd have to go from, a pheno of 2 to 20 is fine, but going from a pheno of 20 to 200 is a bit more difficult, or even more.
Well, as a physiologist, that's a terrific message.
Yeah.
Rory, I have one question for you. The benralizumab versus dupilumab study was very interesting, and you hinted at mucus playing a role. Can you comment on that just a little bit more?
Yes, thanks for your question. So, yeah, we know from Eleanor Dunican's data that interleukin-5 is closely responsible for activating, migrating, and proliferating eosinophils, which then release eosinophil peroxidase that causes the cross-linking of mucin to create the mucus plugging. But also interleukin-13 plays a key role because it results in that mucus hypersecretion from mucus gland hypertrophy. And I think what we're seeing with this data is that dupilumab impacts on both parameters. Although dupilumab doesn't directly impact on IL-5, dupilumab also depletes your sputum eosinophils. So physically, it removes eosinophils as from Param Nair's data. So essentially, you're removing the eosinophils from the airways, which is most important, but you're also providing that anti-IL-13 activity. So in effect, you're targeting both pathways, whereas benralizumab is only focusing on eosinophil depletion in the airways, and to a lesser extent, it doesn't impact on IL-13. So I think that's probably the reason why we're seeing the discrepancy there.
Terrific. Thank you. Chung-Wei?
Thanks, Rory. I missed you at the ATS, so I'm very happy to see this data. In your competence score, you did not take it into account the reactance measurements. And so I wonder if you added, or have you done that, if you added the reactance measurements of the AX to your competence score, did that actually improve your risk assessment?
Sorry, Chung-Wei, the microphone isn't coming through. Great. Are you talking about this slide, is it?
Yes.
The question is whether you took into account the reactants.
Yeah, so I anticipated this question, so I'm very glad. So I created this. This is the only backup slide I have. So we did actually look at. So we actually had the AX data. We didn't incorporate the AX into the original analysis, but we looked at it instead of R5-20, and the results are pretty similar as you can see on the slide.
Great. Yes, Ron.
So, Rory, welcome to Montreal. If only virtually, I'm glad that you were able to present to us. It was a great talk, of course, but I'm biased as well. What software were you using for your quantitative CAT scanning analysis of both paraspinal muscles and the mediastinal lymph nodes?
So in terms of the measurements of the mediastinal lymph nodes and also the paraspinal muscle density, we were using the PACS software. So that was the radiologist who manually measured the values. And then just in terms of analysis, I'm a very simple clinician, so I basically just used SPSS for the analysis.
So get your hands on Total Segmenter. It'll streamline that workflow. We operationalized it in my lab last year, and there's multiple organs across the body, including the ones, paraspinal muscles, that you can volume render quite easily. We're actually looking at the PAA for exacerbation, but not only in the area as published by Wells, but we're also doing a volume rendering of a segment of it to see if that actually, like integration, will improve the signal. So you should get that and play with it. It's very doable. If you need help, be in touch.
Be in touch. Thanks.
Any other questions? Thank you so much, Rory. That was terrific.
Thanks very much. Cheers.
Okay, our next speaker is Dev Patel from here at McGill, one of Ron's proteges. And let's see, did you manage to get it uploaded?
Well, I was going to take it off. So this is me. So, and that's you. Okay, so let's go in here. We should share screen and that's what we're doing. We can move everybody off. If I move around from the people, they won't hear you. Got it. Got to stay close to me. I'll sit. All right.
Hey everyone. So I'm Dev. I'm an upcoming second-year medical student here at McGill. Very excited to give this talk. Very grateful to be here. So the talk today is going to be.
Not shared.
That's not shared.
What? Okay, not shared. The screen's not shared. Okay. Simple. Where will we get there? And we want to here. That's good. How are we now? Okay. Sorry about that. Okay, here we go. All good. Yeah.
Oh, okay. All right. So, hey everyone. Just to, I guess, recap, I'm Dev. I'm a second-year medical student here at McGill. Very excited to be here. Very grateful. Really excited about this talk. I feel like it's going to have an immense clinical impact. So here we go. All right, so I'll be talking about the diagnostic potential of spectral oscillometry versus spirometry in asthma today. It was a retrospective chart review that I did in Dr. Dandran's lab. Why is the slideshow not moving? There we go. All right, so I'm going to bore a lot of people with this slide, but neither to say it's very important. So asthma is the third most common chronic condition, affects about 4 million people across Canada. It's characterized by inflammation and narrowing of small airways. And obviously, poorly controlled asthma is going to be associated with a decreased quality of life, permanent, irreversible damage to airways. So the rationale behind this project was that currently, to confirm spontaneously variable or methacholine-induced airway constriction, we need spirometry, and that's going to establish the diagnosis of asthma. The problem with that is it's going to take about 75% of small airways to be dysfunctional before we reach expiratory airflow limitation. Now, that's a lot. Oscillometry, on the other hand, is simpler, faster, and easier to perform. And it's also why we're all gathered here today. It's going to detect EFL when about 20% of the small airways are going to be dysfunctional. The hypothesis for our project was that the role of oscillometry in asthma diagnosis is evolving and it remains unclear. So to explore its potential, we conducted the study to determine what role oscillometry plays in asthma diagnosis. Our hypothesis was that oscillometry may obviate the need for more complicated spirometry-based tests in some asthma subjects. So the materials and methods. First thing you guys are going to see is Connor McDavid on my slide. I don't know if any of you here are hockey fans. I take it not. All right, that's fine. Greatest player of all time, but that's besides the point. So the reason why he's on my slide is last summer, I had to conduct a retrospective analysis of 733 subjects. And that was during summertime when all the medical students, are supposed to have time off. So I felt like I had no life. And Tony, can you please get up or raise your hand or whatever? So that's Tony, everyone. Tony and I, alongside my friend Daniel here, we were, meeting up for a beer and watch the playoffs last year, Panthers versus Oilers. And I was complaining about this project to Tony, and I told him, I'm like, I have to review these 700 plus charts, and it's taking a long time, and this and that. And plus, I have to extract all the PFT values and the whole shebang, So then Tony's like, well, I could develop a software that's going to streamline the whole thing. And I'm like, oh, perfect. And so he developed a PFT splitter, which takes a PDF of, let's say, 10 plus PFTs and splits them into individual PFTs using optical character recognition. And then after that, he developed a PFT extractor, which takes all the relevant values from the pulmonary function test, again, using optical character recognition. So I was able to get through all these charts last summer, and we included adults that were above 18 and with less than 10 pack years smoking history. The asthma diagnosis was established by the physician, Dr. Dandran, and all the following 4 criteria were used. So post-bronchodilator reversibility, methacholine-induced airway hyperreactivity, peak expiratory flow measurements at home, or a positive response to a diagnostic trial of asthma. And this was the gold standard for the project. If there was an interval longer than 6 months between the oscillometry and the methacholine, we excluded the patients. And we had a final sample of 59 subjects, 39 asthmatics, 20 non-asthmatics. Now, again, this was a retrospective chart review. The data we collected, we had biometrics, spirometry, oscillometry, and lung volume testing. All the data were extracted from electronic medical records, and if we had any outliers, we reselected them with the tracing on the TremoFlow software. For the normality assessment, we used visual inspection and the Shapiro-Wilk test. We saw that the data was non-normally distributed, which is why we used the Mann-Whitney U to test the differences between asthmatics and non-asthmatics. We then visualized the data with box swarm plots, and then we partnered up with Dr. Ross and Sayad, who are not here today, but they conducted the diagnostic evaluation for this project. So we'll start off with the biometrics. We had age, smoking, pack years, sex, weight, height, BMI. All of them were not statistically significant, so not confounding. And then we had the spirometry values. Now, spirometry as we could tell, the FEV1 and the MMEF is going to be lower in the asthmatics. And it's, again, significantly different between the asthmatic and non-asthmatic group. Now, this slide is where things get interesting. So AX is statistically, it was the parameter that was the most statistically significant out of all the other parameters that we analyzed. And it was also significantly higher in asthmatics compared to non-asthmatics. So that was a very key takeaway there. Now, if we look at the box worm plots here, we have the FEV1 on the left side and then the AX on the right side. And we see that FEV1 in asthma patients is obviously lower, whereas the AX is going to be higher in these patients, which is, again, a very important takeaway. And then if we look at the methacholine versus AX, we see this very, very important threshold, the 15 centimeters H2O per liter. So everyone under it in this specific population has no asthma, and everyone over it is going to have asthma. Very, very important again. All right, and this table also super important. We evaluated different thresholds for the AX and the methacholine for sensitivity, specificity, positive predicted value, negative predicted value, and accuracy. Now, the reason for choosing these thresholds 5, 10, 15, 20 is, as a clinician, you're not really going to use a threshold of 14.99876 or whatsoever, right? Way better to use 15, makes all your guys' lives easier. And this one also had the highest accuracy. So the conclusion of the study is that the oscillometry AX parameter performs comparably or even slightly better than the methacholine PC20 in distinguishing asthmatics and non-asthmatic subjects. The potential clinical impact in very big character there, oscillometry could eliminate the need for methacholine in about a third of the patients. Now, I know oscillometry is not going to be able to fully replace methacholine for diagnosis. Our study has very important limitations. Our sample size is small. It's a single standard study, and it's also retrospective. So for the future directions, we're going to validate it in larger independent data sets. So we're actually already starting that process with Dr. Oppenheimer. I don't know if he's on the Zoom. He's not. But yeah, we're partnering up with Dr. Oppenheimer at the NYU to validate our findings. There's also ongoing analysis with the intra-breath oscillometry to see if there's another parameter that might be more sensitive. And we're also going to take away prospective validation. I just want to thank Dr. Ross's lab, Dr. Ross, for running the stats, and Dr. Dandran's lab. Anthony, again, you guys saw him earlier. Zlatzi, Tina are not here today, but just wanted to thank them. Also, right before I finish, just wanted to say, I feel like studies like this are very important, especially in community settings where physicians might not have access to the resources that we do in Montreal. So yeah, very important. And thanks a lot, guys. Happy to talk also if you guys have any questions, want to collaborate. I didn't put my email here, but it's very simple, dev.patel@mail.mcgill.ca. Thanks so much.
Great job, Deb. Really impressive work. And I hope you bought your colleagues an extra beer for all that work.
Yeah.
Are there any questions for Deb? Yeah, Jason.
Yeah,
you come
very
on up.
nice study. You know, I don't think the issue is whether oscillometry replaces a methacholine challenge, because they're not the same kind of animal. But I think I actually went through a complete methacholine challenge once myself because we were testing our gear.
Mhm.
I did both with oscillometry and with spirometry. And the oscillometry turned out to be both more sensitive and, most importantly, a hell of a lot more pleasant to do. Because I don't know if anybody's been through a full. I'm not asthmatic.
Yeah,
I go
my
through
grandma's.
every damn dose, and it was terrible. So I think one thing's absolutely for sure is oscillometry ought to take over from spirometry when you're doing methacholine.
Thank you. Well, yeah, my grandma's been through it multiple times. Another reason why I took this project. I feel like it's a pain to go through. And yeah, if oscillometry could eventually, replace it in the clinical setting, it would be very, very good. Dr. Charlie, right?
Sure. Well, for years, we
Yeah, that's another pain. Yeah.
But we did that along with spirometry. Didn't find it added as much as I thought it might. So I think we need to learn more about it. But this is actually a curiosity question. So I write the up-to-date card on bronchial challenge for asthma. And when I had to revisit and update it recently, and start running stages in the literature, I found almost nothing in the last 3 or 4 years on methacholine challenge. So my question really is just for my own curiosity.
Mm-hmm.
It's been my impression there's a whole lot less polling being done since the pandemic. Is that a fair statement? Okay, thanks. It's what I would have guessed because it's an aerosol generating thing. We stopped doing it for the most part.
For research.
For researching.
Yeah, but we had to scramble long and hard and ask many people to find somebody who had the equivalent data to what we had in order to validate. So my observation is the same, it's dropped off.
So if there's less methacholine challenges being done here in the home, in Canada, in the home of methacholine challenge, then that answers my question. So that
We had a pause with mannitol, but now we've gone back to methylcholine. The kids certainly didn't like the mannitol.
Mannitol's awful because it causes cough.
Yes, I know. I've tried it. I've tried a mannitol gel.
It's bad.
Yeah.
Can I, is the issue you don't like methacholine or you just don't want to do a bronchial challenge, period?
Well,
What's
the issue is that my anecdotal observations of seeing patients lie was, if their AX was high, they always would come back with positive methacholine. So I'm saying, well, why am I bothering? They sound like an asthmatic, the oscillometry looks like an asthmatic, why don't I simply treat them? And so I said, why don't be a little bit more scientific? So this is the project I gave to Dell, to say, well, where is that threshold? And so that's why we explored various levels, 5, 10, 15, 20. And it
Okay,
turned out
but
to be solid.
do you find people who have a normal AX, but you're suspicious for some reason?
Yeah.
Do a methacholine and that they're.
They'll be positive.
Because they need to do it.
Yeah, absolutely. It's only 1/3 of the patients that I see in my practice that I might save the methacholine, but that's still a lot of resource on a global level if this is true.
I guess one reason why you're doing less methacholine if you're using spirometry is just a pain in the ass.
But I agree with you, when if they do, that other 2/3 that need challenge, if we're going to do it, we should be doing with oscillometry. We're shooting ourselves in the foot with spirometry. It's like, take this stuff to bronchoconstrict, and then take this deep breath in and you'll bronchodilate. And so we end up torturing them unnecessarily and using more drug.
Yep.
Very.
Yeah, I'm gonna do methacholine challenge, in my cohorts for testing drugs, because for certain, drugs you cannot, test without any allergen or methacholine challenge, especially if you want to study like small airway disease or depend on the mechanism.
Is this for third-party payers for the drug or is it research?
For my company.
Okay, yeah.
Yes. And I believe this, if you look at the Zapelomab study, that's what they did for one of the clinical trials, they did the allergen and methacholine challenge. Unfortunately, they didn't have the oscillometry data, on that, which I regret. But there is a drug targeting MFP12 that they did oscillometry, and they show changes on oscillometry on that data.
You guys saw Leonard stand up before? And then
Jason asked the same question.
Oh, someone.
Oh, yeah, France is online.
France, go
Yeah, people might remember that I was, together with Peter Sturck, head of the ERS ATS task force about direct bronchial provocation testing. And Alan Coates and Bruce Culver were from the ATS side. And at that time, the paper was published in 2017 as the ERS ATS standard on direct provocation testing. We had a huge discussion, should we include oscillometry as an outcome measure, because already in the 1993 ERS standards, Peter Sturck stated that oscillometry was way more sensitive than FEV1 measurement, let alone the change in bronchomotor tonus due to the FEV1. But then it was decided that since less than 5% of the labs in worldwide who do methacholine challenges do have an oscillometry device, we did not take it as an outcome measure in that report, which I found a pity, but it is. So I hope in the next report, somebody can, that we can say there are more labs having an oscillometry device, and this is a more, a way better outcome, and might even replace methylcholine challenges if we do see this talk. But this is just the pity that we didn't take it in due to the fact that almost no labs do have it, and if they have it, it's only mostly for research purposes.
Thank you. Did you have a question?
Just a quick question for the audience. With a validation cohort, would this be publishable in the Blue Journal? What do you guys think? No? What would be a more realistic target?
Well, anything but the blue, because they're not interested in it unless you've got some sort of molecular this, that, the other.
ERJ maybe? Yeah. Okay.
ERJ is
Still help find it.
something that bar should be.
Right.
Can I ask you,
Or add,
talking about that, it's more sensitive. But what it's done is you're comparing it to your PD20, which is done by spirometry to come up with your cutoff. So how you say it's more and you're saying, but you know, you have the volume history affecting that. So how can you say it's more sensitive? The only way to say is that you did a different cutoff for oscillometry and that it predicted that you were gonna have symptoms.
We're not saying it's more sensitive. We're saying if you're AX 15 or above, there's no point in doing a methylcholine
because you're gonna be
always going to be positive. That's all. So it's basically a time saver workflow.
Yes.
The sensitivity issue is completely different. If one has to do a challenge on a patient, what's going to be the better one to do? The spirometric one or the oscillometric one? And we'd argue the oscillometric one makes more physiologic sense because you're not bronchodilating after every single challenge.
But then you have to decide what value you're gonna call.
There's a lot of work to be done.
It's still
Sensitivity.
using the quiet breathing approach of giving methylcholine.
yeah.
Yeah.
Canadian, the title. Through,
Quiet breathing.
methylcholine by the tidal breath, the Canadian.
Yes,
Yes, I think.
yeah, it's used dosimeter, but yes, it's tidal breathing.
But to address Larry's question about sensitivity, what I meant by that was, if you look at the fractional change in FEV1 given dose of methylcholine, it is less than the fractional index of AX.
Okay.
So you just get a bigger response, which means you have more sensitivity.
Okay.
All right, great discussion. Thank you again.
Thank you. Thank you.
Okay, last but certainly not least, we have Olivia Gator from University of Western Ontario to present, does oscillometry differentiate patients with severe asthma in clinical remission? And is your talk on?
Should be down here. This one. Screen share. I think we have to.
Put yourself in the presentation.
All right, there we go.
Yeah.
All right, thanks for sticking around, everybody. Last one, we made it through. Good morning, my name is Olivia Gator. I have finished the first 2 years of my undergraduate degree, and I'll be starting an honors specialization in biochemistry in the fall. For about 2 years now, I've been working under Dr. Grace Perga in the Advanced Pulmonary Imaging Labs. And today I'm going to be talking about oscillometry measurements and whether they can be used as predictors of clinical remission in patients with moderate severe asthma. So as I'm sure we're all familiar, asthma is a progressively worsening inflammatory airways disease. It is heterogeneous, meaning it has many clinical manifestations or phenotypes, but it is characterized by variable expiratory airflow limitation and symptoms. A person with asthma can experience some or all of the following symptoms, and all of these can result in missed work and school days or hospitalizations. Asthma is typically diagnosed on the basis of variable expiratory airflow limitation and the presence of these symptoms. The Global Initiative for Asthma recommends asthma prescription management based on the retrospective assessment of loss of disease control in exacerbations. In other words, you fail first then you treat. GINA defines disease control based on these perceived symptoms and rescue inhaler use. So the key takeaway is that GINA does not incorporate pathology, airway inflammation, oscillometry, or imaging markers in the assessment of disease severity. And to illustrate why this doesn't paint the full picture, I'm going to use myself as an example. I was diagnosed with asthma about 2 years ago. I am GINA step 4, which means I am controlled on high dose ICS LABA/LAMA. However, my pre-bronchodilator FEV1 is 97% predicted. So it's interesting. Just a brief overview of asthma pathophysiology. The airways are divided into the conducting and respiratory zones. Conducting zone acts as conduits for inhaled air, and the respiratory zone participates in gas exchange. We've talked about small airways dysfunction a lot, but when we are talking about the small airways, we are referring to these airways in the respiratory zone less than 2 millimeters in diameter. Just taking a look here, we have a healthy airway. As we can see, we have a few submucosal glands, a regular epithelial membrane, a thin airway smooth muscle layer. But when we take a look at an asthmatic airway, we can see a very prominent airway smooth muscle layer, disrupted epithelium, many more submucosal glands, and mucus plugging. Altogether, this thickening of the airway, or the airway wall, narrowing of the lumen, and mucus occlusion contribute to what we call airway remodeling. And this can lead to progressive loss of lung function. Compared to just simple symptom control and exacerbation, clinical remission has emerged as a new treatment goal for patients with asthma. Clinical remission consists of 4 domains. The first is no oral corticosteroid use. The second is no exacerbations. The third is improved lung function, which we measure with an FEV1 greater than 80% predicted, and improved symptom control, or an asthma control questionnaire score less than 1.5. A patient is said to be in complete clinical remission if they have achieved all 4 of these clinical domains. However, we can measure improvement by counting the number of domains a patient is able to achieve. So it's important to note that clinical remission in moderate severe asthma is challenging to achieve and predict even with biologics and inhaler therapies. So as we've said before, small airways dysfunction is the narrowing or obstruction of those distal airways in the respiratory zone, and it has been shown to be significantly associated with poor symptom control. And oscillometry markers can sensitively detect the abnormalities in the small and large airways, and these also have been shown to be significantly correlated with imaging markers and quality of life scores. So given that symptoms and exacerbations are both part of clinical remission, that leads us to our research question, which is, does oscillometry predict clinical remission in patients with moderate severe asthma following treatment? So to investigate this, we retrospectively evaluated 62 participants with moderate severe asthma. 31 of those participants had severe eosinophilic asthma and were enrolled in our airflow study, which consisted of a baseline visit with pulmonary function testing, force oscillation technique using the TremoFlow device, hyperpolarized xenon MRI, CT, symptom control questionnaires, and then inflammation markers. Those patients then started on anti-interleukin receptor 5 alpha, or benralizumab, and they came back for a 1-year visit and a 2.5-year visit. The other 31 participants had moderate severe asthma, and they were enrolled in our ETHA study, which consisted of a similar baseline visit to the airflow study, except they were started on single inhaler triple therapy, which is a combination of ICS, LABA, and LAMA. Those patients then came back for a 1-year visit. So here's just some preliminary results of our pooled analysis. It's quite busy, but there are 2 things I want you to focus on. The first are these oscillometry markers. As you can see, they significantly improved with treatment. And the second is clinical remission achievement, also significantly improved over time. So the treatment worked, essentially, which was good to see. And then we're taking a look at just clinical remission achievement. This figure here shows the fraction of participants who achieved 0, 2, 3, plus lung function, meaning they achieved the first two domains of no oral corticosteroid use and no exacerbations, and then improved lung function. 3 plus control, so again, those first two domains, and then improved symptom control, and then 4 domains of clinical remission. At baseline, we can see this very large fraction of participants who had no domains of clinical remission. So they had an exacerbation or required oral corticosteroids or both within the 12 months leading up to this visit. And again, and this very small fraction of participants who are already in complete clinical remission at baseline. At 1 year, we can see a dramatic improvement of patients who achieved clinical remission and a very significant decrease in patients who had exacerbations or oral corticosteroid use. And this trend, again, we can follow and see the significant increase in clinical remission achievement and decrease in exacerbations and OCS use. But where does oscillometry fit into all of this? So here, I'm going to show the mean oscillometry values for participants who achieved 2, 3, or 4 domains of clinical remission. As you can see, R5 was significantly different between patients who achieved 2 domains of clinical remission and 3 domains of clinical remission at 1 year, and again, 2 and 4. R5 minus 19 was also significantly different between 2 and 4 domains achieved, and X5 was significantly different between 2 and 4 domains achieved. So oscillometry markers improve alongside clinical remission achievement. So this figure is similar to the previous one, except this time we are looking at the mean baseline oscillometry values between patients who achieved clinical remission at 1 year and those who did not. So easy to see there's no significant difference between those baseline oscillometry values. However, when we looked at imaging markers, like total airway count, there was a significant difference between patients who achieved clinical remission at 1 year and those who did not. Total airway count has been shown to be significantly correlated with symptom control. So in this case, patients who were worse were more likely to get better. But our question was, does oscillometry predict clinical remission in these patients? So to evaluate this, I performed a backwards stepwise binary logistic regression with oscillometry, CT values, and looking at clinical remission achievement. There were 3 models that performed significantly better than random guessing. Model 1 was the best. It had an 82% predictive accuracy and included R5, R5 minus 19, and total airway count as significant predictor variables. To evaluate model performance, I used an ROC curve. Model 1 again had the best performance with an AUC of 0.89, which indicates good discrimination between those who achieved clinical remission and those who did not. But if we take a look at the individual contributions of each of the variables, we can see that a worse baseline R5 and a worse baseline total airway count increase the chances of achieving clinical remission at 1 year. However, a better baseline R5 minus 19 also increased the chances of achieving clinical remission at 1 year. So in conclusion, we can see that baseline oscillometry values together with CT measures can predict clinical remission achievement in patients with moderate severe asthma following therapy, which could help identify those patients who are most likely to benefit from these costly therapies like single inhaler triple therapy and biologics. To further investigate these promising results, we plan on quantifying oscillometry measures in patients with both clinical and imaging remission and those who achieve neither. If you aren't familiar, imaging remission refers to the reversal of airway remodeling and the pathologic normalization of asthma. And we also want to explore the relationships between oscillometry, inflammation markers like fraction of exhaled nitric oxide and blood eosinophil count, and clinical and imaging remission. Thank you so much. Also, big thank you to everyone in my lab who helped me out with all of this. And big thanks to Dr. Grace Perica for letting me be here today.
Thank you, Olivia. That was terrific. Really great. Questions from the audience first, and we'll look online. Larry?
Yeah, that was a fantastic presentation. Congratulations. So you're saying, if you start off crappy, you're more likely to respond, but
Yeah.
if you're good already, adding a biologic didn't seem to push you over the.
No, not with clinical remission achievement specifically. And we also saw this with, it's been shown with imaging markers too. So if you're looking at VDP, total airway count, wall thickness percent, the worse you are, the more likely you are to get better.
I had one question, and that is, how did FEV1 perform in your modeling?
FEV, so I didn't include FEV1 because clinical remission depends on FEV1. So it is significant, but if you're using it to define if someone's achieved it, obviously the better people are. Yeah, so it was conflicting.
Yeah.
Yeah.
Really nice, really interesting information. You didn't really tell us both total airway count and oscillometry, R5 in particular, were very good at predicting when together. You didn't really separate which one contributed more if there was a difference. If I saw correctly, the odds ratio column, the odds ratio column for R5 was 5, but for total airway count, 1. My second part would be, how small airways can you count? Like, what's the resolution of the imaging?
So for the first question, if my understanding is correct of the statistics, I wouldn't say it's my strong suit. Odds ratio is talking about like a 1 value increase, the change in like the predictive accuracy. So total airway count is usually very high. So if you go from 203 airways to 204 airways, like I'm not even sure that we could for sure say that that's just not observer error. But if you go from, an R5 of 2 to 3, that's a big difference. So I think it's reflective of the fact that TAC we're talking about bigger numbers in general, and we can see bigger variation, whereas our is smaller. In terms of resolution, we can see, I think, up to generation 11 on a CT scan. So it's a very painstaking process where a single observer has to go through and look at every slice and manually segment out those airways. And it does depend a little bit on the quality of the CT scan, whether the patient was coughing, how much noise there is, but generation 11 is about where we can see.
Is that diameter 2 or is that diameter 1 or?
That's a great question.
I think it's 2 millimeters.
2 millimeters,
Yeah.
right down to the small.
So is the thinking that, you mean as the airways expand, more of them are identifiable? Is that why the airway number changes? Because you could just see more of them?
Yes.
Yeah.
Yeah. So the better this, as CT scans get better, we can see more.
Any online questions there, Ron? Do you see?
No, looks like we're pretty quiet over there.
Okay, if no other questions, thank you so much again. Great job.
Well, thank you, everybody, for hanging in there. With that, we'll close down the seminar and let's roll up our sleeves. First relax, but then roll up our sleeves and get some work done for next year. And look forward to interacting with all of you at the meetings that we'll be having around the world as well as locally. Thank you again for all our speakers, our corporate sponsors, our trainees who are going to be carrying the torch later. The students are equally important. So have a great afternoon, everybody, and enjoy Montreal.
Thanks.